our session. I am Mustafa Al-Shazli, Professor of Pulmonary Medicine and Respiratory Critical Care, Cairo, Egypt. I'm delighted to co-chair this session with Dr. Faiz Al-Ahmadi, which is Consultant Pulmonary Medicine, Pulmonary Hypertension, and Pulmonary Angioplasty, King Faisal Specialized Hospital and Research Center, Riyadh.
Thank you, Dr. Mustafa. Today we will have 3 morning sessions, starting with the miscellaneous session, then a SAPH session, and we'll end up having international perspective. It's actually my honor and pleasure to introduce Prof. Gianluca Bashiri. He's a clinical professor of cardiology and director of the Pulmonary Vascular Diseases and Heart Failure Clinic at University of Brussels, Belgium. Dr. Bashiri was the chair of the PH Council at the ISHLT from 2018 till 2020. He was being involved in the World Symposium of Pulmonary Hypertension as a task force member in 2003 and was a co-chair to the task force on pulmonary hypertension due to left heart diseases for the World Symposium back in 2018. Dr. Bashiri will talk today about PH with cardiac comorbidities and combined post-capillary and pre-capillary pulmonary hypertension. Dr. Bashiri, please, the floor is yours.
Thank you very much, Faiz and Mohammed. Assalamu alaikum. Thank you again for this kind invitation, Abdullah. It's always a pleasure to come and meet friends. There's science and friendship, and it's always delightful to come over here in Saudi Arabia. So this is a real problem we're having here. PH with comorbidities and pulmonary hypertension owing to heart failure with the pre-capillary component, which is phenotyped as CPC-PH in terms of hemodynamics. So I'm going to try to tackle that question in the next few minutes. These are my financial disclosures. So if we look at the current classification, there's absolutely no doubt that if we look at the risk of overlap and confusing phenotyping, it's clearly in the field of idiopathic PH and pulmonary hypertension associated with heart failure and preserved ejection fraction. Probably the valvular heart disease is less of a problem in terms of differential diagnosis. Now, the question, of course, is due to the question that arises, what can be the therapeutic consequences? Well, there are twofold. Either you misdiagnose a PH with HFpEF, and then you don't give the appropriate treatment to the patient with PH, and the reverse is true. You may treat a patient with a PH associated with HFpEF with PH drugs, which we know is really not appropriate. So this distinction is not only important in terms of clinical decision-making at the bedside, but also in randomized controlled trials. And I would like to put a little bit of light on this specific question. The difference, in fact, in pathophysiology exists between the two entities, but it's not too much difference. That would be surprising to you, but I would put forward to you that there are some commonalities. Let's first look at the response to exercise of patients with group 2 as opposed to patients with idiopathic PH. And let's look at the VVCO2 slope, which is probably one of the best indicator of an abnormal cardiac adaptation and surely of the presence of a pre-capillary component. In fact, this relationship gets steeper and steeper as much as pulmonary hypertension develops, and within the field and within the, let's say, the range of pulmonary hypertension, of heart failure, it gets steeper when the pre-capillary component starts to develop, and patients with CPC-PH owing to heart failure with preserved ejection fraction have a VVCO2 slope that is not different than the one with idiopathic PH. So from an exercise standpoint, we can see the same or some similar features. It has been also shown by the group of Barry Borlow very recently, where they wanted to see whether what I showed you in the previous slide was true, i.e. whether there would be a different signature in pre-capillary pulmonary hypertension in patients with heart failure. They call it latent pulmonary vascular disease or pulmonary vascular disease in the context of HFpEF. they did an exercise test to all of these patients, compared them between the spectrum of normal patients, patients with heart failure without a pulmonary hypertension isolated, and CpcPH. They also did an analysis of the coupling of the right ventricle to the pulmonary artery during exercise, and also looked at the level of congestion in lungs by doing an echocardiography, a lung echography during the exercise. And what they found is a very different signature in the patient who have a precapillary component, who in fact behaved a little bit more like PH than the patient with conventional heart failure. There are greater induced lung congestion, there's arterial hypoxemia in those patients, there's more uncoupling, there's more ventricular interdependence, and there's also an impairment in oxygen delivery. And in fact, this is a very unique signature in those patients. And surprisingly, they were able to demonstrate that despite what we would believe, the level of congestion was still very high in those patients during exercise, which may explain also why the VCO slope gets steeper and steeper. So differences there are, of course, but there's a signature here of precapillary component in patients with heart failure. Now, if you go deeper in the mechanism of disease, this is the current state of understanding of the molecular changes in patients who have heart failure, irrespective of ejection fraction. I don't want to detail that, it would drive us a little bit too long, but if you look at that, you will recognize some common features with PAH and pulmonary hypertension in general. So there is endothelial dysfunction, there are changes in the target organs from inflammatory mechanisms or proliferative mechanisms, that each of them being potentially a target for treatment. So the endothelial dysfunction that is found in heart failure is kind of similar to the one we may find in pulmonary arterial hypertension. However, there probably are different genetic signatures, and we're trying to tease that out a little bit better now, although there are, again, some common grounds leading to heart failure. The clinical expression of this is leading to different phenotypes. So even in CpcPH or pulmonary hypertension with heart failure, you have different phenotypes. You have the young patient with exercise-induced increase in left atrium. You have the elderly woman with systemic hypertension, obesity, and coronary artery disease. And you have the old man smoker with pulmonary hypertension. And within that, you also have different phenotypes. One of the most recent features to understand the mechanism of pulmonary hypertension in the context of heart failure is what is called now atrial failure. This is a quite new concept that has been put forward by physicians who observed that patient in atrial fibrillation or patient with normal left ventricle going in atrial fibrillation and then repetitive ablation start to develop pulmonary hypertension because their left atrium is becoming very stiff. There was a very interesting and vivid debate on Twitter last week about that question, and should we measure LVDP, should we measure left atrial pressure? I guess that all the members of this community, and some of them very respectful, would agree that the left atrial pressure really is the problem in the development of pulmonary hypertension. In contrast, LVDP has a different signature. It signs for the left ventricle. But the molecular mechanisms and the cellular changes occurring in the atrium are way different from the ones we see in the left ventricle. So there's clearly a contribution of left atrial failure to pulmonary hypertension in left heart disease. And in contrast with what's happening in PAH, one of the mechanisms, or actually the mechanism leading to pulmonary hypertension, goes both ways. There is, of course, a problem of RV afterload in heart failure or in left heart disease. So the increased afterload leads to the RV to PA uncoupling. But there's also a preload insufficiency that is due to the presence of a tricuspid regurgitation, which is again much more common in patients with atrial fibrillation, an uncommon feature in PH, but very common in patients with heart failure. On top of that, you can add a layer of difficulty, which is a direct right ventricular insult in patients who have heart failure with preserved ejection fraction. The way we tackle this, or we suggest to tackle this, and this is something that will be discussed and likely proposed at the future World Symposium, is to get more in a proper phenotyping before bringing a patient in the cath lab. And we have tools to do that. It's very important for us to make that distinction between CP-CPH, or let's say pulmonary hypertension associated with heart failure, and patient with PH. And the suggestion is to go to looking at the clinical profile, the echocardiographic profile. We have non-invasive score to do a priori assessment to decide whether a patient should go to the cath lab to get either a right heart cath alone or a right plus left heart catheterization, and maybe in some cases a coronary angiogram. And of course, when you're in the cath lab, the big question is, are you going to rely, are you going to rely on resting pressures, or are you going to do a provocative testing? And clearly, both exercise in the cath lab and fluid loading, just look at this wedge pressure during leg raising. So just leg raising pulls some of the volume to increase the wedge pressure and uncover left heart disease-induced pulmonary hypertension. Now, let's move to the other side, and let's look at pulmonary arterial hypertension and that question of comorbidities. It is clearly a problem. We're facing this every day. There's a change in population. In our registries, we see more and more patients with some traits that may lead or be risk factors for heart failure with preserved ejection fraction. If we go back to what was suggested in the recent guidelines, we have 3 sets of comorbidities that are maybe associated with a higher risk to have non-PH. Some of them are general and non-modifiable. Age and gender, one may wonder or question the fact that these are truly comorbidity. I would say that this is a fact of life. Then you have the cardiac comorbidities pointed out because they are associated with a higher risk of SAPH, and that's systemic hypertension, all kinds of diabetes, previous coronary artery disease, or obesity. And then the last bit, and I'm not going to talk about that, I would be ridiculous talking about lung disease as a cardiologist. Pulmonary risk factors with a risk of group 3 overlap, that's smoking history, yes and no, and DLCO with a cutoff value of 45%. We always start frowning when we see the DLCO lower than 45% in a non-sclerodermic patient. This is something that is maybe a signature in some cases of left heart disease. So these are the comorbidities that are suggested by the current guidelines. There are much more comorbidities if you look at cachexia, iron deficiency, hypo or hyperthyroidism, sleep apnea syndrome. These are frequent and common comorbidities, probably more common in group 2 than in group 1 PH. I got that slide from Athénaïs Boucli and Olivier from their work and in the French registries looking at the burden of cardiovascular comorbidities. In fact, they found that 60% of their patients in the French registry had at least one comorbidity, and the most common one is systemic hypertension. So there comes the question I would say to the audience and to our community to ask ourselves whether one comorbidity sets it all, or if there is a burden, which means that probably that if you have 2 or 3, you have much more risk to have either a diagnosis of PH-HFpEF or perhaps a worse outcome in the context of pulmonary arterial hypertension. And this is something also that we are going to propose at the next World Symposium, which is a scoring system for the comorbidities to see whether maybe we are on the right tracks or not. We'll see. Now, if we talk about treatment, and I think this is important because the response of PH therapies to patients who have HFpEF is way different than what we may expect in PH. One of the drivers of the changes in the current randomized controlled trials and our understanding of comorbidities was started to be raised during the AMBITION trial. If you recall the AMBITION trial, upfront combination therapy, ambrisentan plus tadalafil compared to each monotherapies, the idea was, of course, to get the usual population, the usual population with PH, but then, because those patients were naive, in a new era of pulmonary hypertension, it was the early 2010, we started to see a population with milder pulmonary hypertension and closer to 15 millimeters of mercury of wedge pressure, with a lot of comorbid conditions, prior intervention, etc. So the idea of the amendment of the AMBITION trial was to decrease the likelihood to have those patients in the trial. You see here the original protocol criteria, intention to treat, and this is important. I will show you some numbers just after. It's the usual PVR level, LVDP or wedge pressure at 15, and there was no exclusion of subjects with left ventricular disease. Then risk factors for left ventricular disease. Then the amendment that is called, in the next slide, the primary analysis set that was put forward was that the PVR was heightened to 300 dynes. The wedge pressure will lower to below 12 millimeters of mercury in patients who have PVR above or equal to 300, but below 500 dynes. So it means that in those milder cases, we wanted to have patients who had even lower wedge pressures. And there was exclusion if patients had at least 3 criteria, which are actually the comorbidities that we retained at the guidelines committee. If you look at the outcome data of this primary analysis set, so the patient without comorbidities as opposed to patient with the ex-primary analysis set, so those who were excluded because they didn't meet this criteria, you can see that although there is still a response, this response is blunted. So the benefit in time to clinical worsening in this population with comorbidities is a 30% reduction as opposed to a 50% risk reduction in, let's say, the more conventional PH cases. And if you look beyond that, with some of the details and see if there's something that we can measure to make the difference, in fact, there is little difference in walking distance, NT-proBNP, quality of life, and the rate of hospitalization. The adverse events the discontinuation rate is higher in this population than in the others. So there are more adverse events in this patient with comorbidities, even if they had PH, and this is something we need to, of course, to deal with. Now, if we go back to registries, and if we look at what's happening in Compera, as you know, this is an open registry. Patients are getting in if they receive a treatment for pulmonary arterial hypertension, and you compare this registry with AMBITION, with the AMBITION criteria and the AMBITION population. Atypical, so typical IPH, atypical PH, and PH-HFpEF in Compera. This is how the authors wanted to word these differences. But already you can see that what they call atypical PH, which is PAH with comorbidities, the age and the gender is closer to HFpEF than it is than typical IPH, and even the typical PH are older than the patients we included in AMBITION. If you look at the burden of comorbidities, it's super high in PH-HFpEF. It's mild to moderate in atypical, but also in IPH in the registry, you can expect to have a quite significant number of patients. You see here, it's 43%, it's 10 to 43%. Whereas in the AMBITION trial, the number of comorbidities or the percentage of comorbidities is much lower. But look at this. This is a signature of PH associated with HFpEF. Atrial fibrillation at time of diagnosis. Each time we have a new patient sent to us with atrial fibrillation, this is almost a done deal. We know what we have to do. It's probably a patient who has group 2 pulmonary hypertension. So it's important for us to make the distinction between these 3 entities: idiopathic PH, patient with comorbidities, and of course PH associated with HFpEF, which is a different beast. If you look at the survival analysis and some of the safety analysis in Compera, and we need to take this with a grain of salt because the idea of Compera was not to assess necessarily the long-term outcome, but still, if you look at the survival rate, they seem to be quite similar. If you look at atypical PH, typical IPH, and also patient with PH-HFpEF, it is not unsurprising because you have older patients, and it's very likely that some of these patients had events that have nothing to do with their underlying pulmonary hypertension. What is interesting is that the rate of dropouts for treatment for adverse events, so drug-induced adverse event, is higher in the ERA populations. You have more dropout when patients with, let's say, non-typical PH are treated with PH with endothelin receptor antagonists, whereas in PDE5, it's a lack of efficacy that is the cause of withdrawal. So again, we have here a very different behavior that we can assess from a clinical ground. So that was for, let's say, newly diagnosed patients. Now, if you look at the patients who are, let's say, the survivors, the ones who were hyper-selected, who are surviving pulmonary hypertension long enough, you have a slightly different picture, and this is work that was done by Stefan Rosenkrantz with the Griffon database, where he showed actually that the comorbidities, whether present in a much lower rate in the population of Griffon, the benefit of treatment was quite similar. This is probably due to a selection of the candidates and the natural exclusion of patients with PH-HFpEF. So let's 50% of the patients, by the way, had at least one of the comorbidities. So probably at time of diagnosis, this is where we need to make the job to make the distinction. Then down the road, if a patient gets older with pulmonary arterial hypertension, we're more confident that heart failure with preserved ejection fraction is not a cause of the disease. Let me close with therapy. This is how our community was super successful to bring new drugs on the market with the partnership of our colleagues from industry. This is a change in the treatment recommendations over time. So it's a huge achievement to have guidelines, to have a proposal for treatment algorithm in a rare disease. It's more than 40 studies, it's 40,000 patients plus, and still coming. We heard about the new trials coming up in the near future. This is what we have with the trials with pulmonary hypertension, pulmonary arterial hypertension drugs in the field of heart failure. You see all the acronyms. By the way, there's less than 2,000 patients that were included in those trials. Actually, it's closer to 1,000 than anything else. It's a triangle of sadness. Nothing really works. So I was trying to find a picture to illustrate sadness, and I found one yesterday, which I think illustrating what sadness is. The Saudi trainer was French, Hervé Renard, and it makes me smile because the gentleman who's sad is not my best friend. So anyway, this is what it's looking like when you have an outlook of pulmonary hypertension trials in heart failure. There are still one study ongoing, Cadence with sotatercept. The recruitment is going quite well. It's a 24-week study looking at change from baseline in pulmonary vascular resistance. We'll see if in a population with truly PH associated with HFpEF, we have a benefit of the intervention. The PASSION trial with tadalafil that was spearheaded by Stefan Rosenkrantz and Marius has been stopped according to what people are saying. So I don't believe we will, and I think that patients were withdrawn with their drug. So probably we will not see results from this one anytime soon. If you look across the current, and that's going to be almost my last slide before conclusion. If you look at how we define those comorbid conditions in the recent randomized control trials, I put PROSERA, IMPACT, and INSIGNA PH. It's interesting to see that there are criteria to exclude those patients with pulmonary hypertension associated with HFpEF or too much risk factors for left heart disease. I don't want to detail that, but I'll leave the slide to you if you wish. It's interesting to see how heterogeneous are the criteria, and I think we need to tackle that, and we need to change that in the near future. So let me conclude in two ways. There's clearly a change in the paradigm of pulmonary arterial hypertension that was given by the AMBITION trial, especially with the new amendment, to avoid having patients with traits of HFpEF. AMBITION showed that there's a very different behavior in terms of response to therapy in those patients with were excluded by were not the primary analysis set. And it is important because in our registries, those patients we may treat look like the patients included from AMBITION, and even worse, have a burden of comorbidities that is much higher. We need to harmonize what is the definition of pH with comorbidities, definitely. This is going to be important when new drugs are going to be on the market, especially from a safety perspective. We don't know whether those patients are safe in this situation. Those patients, though, are underrepresented in randomized control trials, and we may ask ourselves whether it wouldn't be time to let's say, unleash a little bit the criteria to get some of those patients in clinical trials. There are two ways to do that. One is led by Olivier Sidbon and Laurent Saval. It's a PHRC. It's a non-industry sponsored initiative led by investigators looking at pragmatic trials to include specifically patients with pH and comorbidities. That's one way to do it. It's a real-life pragmatic trial. The second strategy is to change a little bit inclusion-exclusion criteria in current randomized control trials, perhaps to let a small number of patients, I'm just throwing out 20% of those patients in clinical trials, and have an analysis that would be dedicated specifically to this population. If we don't do it, next year and in 5 years from now, I will be singing the same song again and again. Thank you very much.
Thank you, Professor Luc. Have a seat, okay. Now we are shifting to the second, Dr. Regina, which is cardiology, internal medicine, hospital lens at Osteria. She will talk about implantable treprostinil infusion pump, real-life experience. Dr. Regina.
Ça va, cher? So can you help me? So maybe we start with the presentation, because the laptop does not work. Thank you for being here. It's a great pleasure to present my experience with implantable pumps. I'm coming from Austria. Maybe you can start the presentation from your... Yes, thank you. These are my disclosures. I'm coming from Austria and my institution is situated in Linz. This is the capital of Upper Austria and the region has about 1.5 million inhabitants. In our institution we treat about 200 people with pH, all causes, and 2/3 of all patients are on dual or triple therapy, including treprostinil, sub-Q, and IV. In my talk, I will show you why we need implantable pumps. I will guide you to the implantation procedure, the refill procedure, and I will show you some complications that we handled. There's no doubt that we need prostaglandins. Despite the great effects of the prostaglandin therapy, we have some side effects of treprostinil sub-Q therapy. We have to handle side pain, painful rubor or infection of the infusion site pain, and even we go for IV with external lines, we have to handle with infections. So the wish was to get a pump which can put into the abdominal wall and we can refill the pump out from the outside of the body. Let's go back to the 2000s. We know that infusion pumps were used in pain treatments since decades. Treprostinil stability at body temperature is above 30 days. So the wish was coming up that we have implantable pumps for this therapy. For this therapy, there must be an inclusion alarm, and the pump was CE certified 2009. The first implantation was done in Germany with a filling interval of 20 days. We did the first implantation with a 40 milliliter pump and a filling interval of 28 days in 2010. So that are the features of the pump. Here you can see the titanium alloy which surrounds the propellant chamber. The propellant chamber is filled with inert gas which expands at body temperature and compresses the drug chamber. You have access to the drug chamber via the reveal septum, which can be punctured 500 times. The free septum is marked with a marker that you can find it easier in the patient. Here you have the flow rate chip which determines the flow, the pressure sensor, and the sideboard that gives you access to the pump. We always start sub-Q at our center. We try to titrate up as fast as possible, up to 70 nanogram per kilogram per minute, or if a higher dosage is needed to stabilize the patient, we do that. The patient must, for pump implantation, be stable in condition, functional class 2 or 3, and he has to have unmanageable problems with the sub-Q therapy, pain, infections, or he is unable to handle the external pump. We have a dedicated team for the operation, always the same surgeon, the same two surgeons, and the anesthesiologist are caring for the patients. When we start the operation procedure, if the patient is on anticoagulation therapy, we stop this and normalize the coagulation. Then we give antibiotic prophylaxis, ampicillin or clindamycin, and the patient is given general anesthesia due to the tunneling for the line. So this is the pump implantation process. First of all, we try to do a central venous access. We choose the vena subclavia. Better is to go to the vena cephalica because there's less dangerous for getting a pneumothorax. And otherwise, in the follow-up we saw when we go to the subclavia, there can be a rub of the line due to the claviculum. Next step is the pump pocket preparation in the abdominal wall. The pump is fixed at the abdominal fascia. After that, the tunneling of the line comes. This is the most hardest part of the operation. And then we have to connect the two lines, and therefore we have to use the connector. The connector must be in a coaxial direction, and with the connector we also fix the lines on the fascia. Then we close the skin. Here you can see the pump is in the abdominal wall. Here you can see the line running up to the vena cephalica. 1 hour after the switch from sub-Q to IV, the sub-Q therapy is stopped. In the first patient, we we did this in 2 hours, and we had an overlap, and the patient developed low blood pressure. The patient is monitored for oxygen saturation, blood pressure, and heart rate for 24 hours. And the following day, we do an X-ray, a chest and abdomen to document how the line is going and the pump lies. Here you can see one example. You have to have the right length of the line. Here you can see the connector and the pump, and also the connection between the pump and the line. The next step is the refill 20 days after. You have always to use the refill septum because there's a special needle. Other needles would damage the refill septum. Then we prepare the solution of treprostinil and sodium chloride. Because the pump runs on a fixed rate, we have to dilute treprostinil to get the right dosage. Then we do an aseptic disinfection of the skin. We puncture the refill septum, and when we are in the right place, we get a reflow. Please, can you start the video? It's not possible. You get a reflow of 5 to 4 milliliters. It depends a little bit on the pump rate. You have to document the reflow by every refill, and then you disconnect the syringe and you start the refill. You have to put the fluid into the pump. You have to test if you have reflow or not. If you don't test, you have the opportunity that you got out the needle and you do a paravasat with an overdosage of treprostinil, and then we have the end of the refill. We tried to put all our patients together. Up to 2019, we implanted 85 pumps. We did more than 2,000 refills, and we saw no infection of the pump or of the refill site. And we showed also that it's safe to switch from sub-Q to IV in step 1 by 1. We analyzed also the 17 patients with inoperable SAPH, and we observed that there are no additional safety signals. We have no catheter-related infection and no thrombotic events were observed. Also no clotting of the catheter. We are not the only group in Europe. You can see in this busy slide there are a lot of groups doing Lenus Pro implantation. In our experience up to now, we have performed 138 pump implantations in 107 patients, also patients from other sites. We have to replace 28 pumps due to an increase of the flow rate and to a shortening of the refill interval. But there was no danger for the patient because the increasing of the dosage went slowly. 3 pumps were changed to a 60 milliliter pump because of dose increasage in the patients. What we saw outside, we saw 1 twisting of the pump to failure of the fixation. We saw 2 tear outs of the line and 2 cases with non-axial connection between the line or between the line and the catheter, and 1 fray out. We have had 2 perioperative pneumothoraxes and 1 hematothorax and 1 wound healing disorder, which happened, and we decided to remove the pump, put the patient 4 weeks on sub-Q, and we go for further implantation. Here you can see the non-axial connector in this way. This shows you there's the fray out of the catheter. The patient explained about pain like sub-Q therapy. She did gardening and window cleaning, and due to the arm expansion, the catheter was rubbed. And here you see the case of a young boy who go mountaineering with the pump and mountain biking, and due to the hits he get to the pump, the catheter is not in a coaxial position with the line. So we have to remove the lines and the pump. As you can see here, due to the pumping of the needle, the line is damaged. Next, I will show you two cases who were admitted to our hospital. The first case shows that the alarm was triggered due to an occlusion of the line, and this is due to a long line which was kinked when the arm were moved. So we have to replace the system, and the other one was also, you can see the loopings which got to a kinking of the catheter, and we have to remove the whole system. Currently, we have the regulation status that no pumps are available. The CE certificate expired due to an administrative regulatory reasons, not to pump reasons. That's very important. And in the US, Medtronic stopped the activities for implantable pumps. We hope that we get a new pump in 2026. And I cross the fingers that will be so. For me, the implantable pump helps to overcome side effects of sub-Q therapy. Patient must be in a stable condition for safe implantation. In long-term follow-up, some manageable catheter problems happened, but no infections, and all patients say that they have an improvement of quality of life. Thank you for your attention.
Thank you, Dr. Regina. Please join us on the stage. So our next speaker is Prof. Majdi Idris. Prof. Majdi is Director of the Pulmonary Vascular Disease Unit at the Prince Sultan Military Hospital in Saudi Arabia, Riyadh. He's an adjunct professor of pulmonary medicine at the University of British Columbia, Vancouver, Canada. He was actually the first to establish the pulmonary vascular diseases, pulmonary hypertension medicine in the Arab Gulf countries, and he was the former head of the Saudi Association of Pulmonary Hypertension. Prof. Majdi will speak about pH in chronic hemolytic anemia. The floor is yours, Prof. Thank you.
Assalamu alaikum wa rahmatullah. Salatu wassalam ala Sayyidi Rasulullah. Thank you, Faiz, for the kind introduction. And thanks, Abdullah and Raghda, for the invitation. So I'm going to be talking today about sickle cell disease. I've been doing that for the last few sessions. And I remember this slogan like, basically, والنون تحلو في فمي أبدا حتى كدت يقال لي ذنوني. فأنا basically with the sickle cell and pulmonary hypertension, very frequent topic. So let's talk about what's new in this when we talk about hemolytic anemia and pulmonary hypertension. This is not a new entity. It's been there for the last 30, 40 years when we found out this association between the two diseases, sickle cell disease, hemolytic anemia, and pulmonary hypertension. And in this review back in 1982, the author described 6 cases who died because of pulmonary hypertension. And really at autopsy, they really described what they call the vasculopathy that was associated with sickle cell disease and hemolysis that led to the death of those patients. Now, initially, if you look at where we used to really categorize or really classify hemolytic anemia back on Venice on 2003, it really belonged to group 1, where we believe that it is the vasculopathy, basically plexiform lesion involvement, so that fits there as an other under one of those subclasses. Now, it was until Dana Point back on 2008 where people start thinking about it. This is more complex than to be basically grouped under group 1. And there was no clear, basically, evidence that there is active basically plexiform lesion basically in those patients. They thought that at autopsy, those patients actually, when you look carefully, it's more like thrombosis versus plexiform lesions. So the disease was reclassified under group 5, and it continued to be under group 5 until the last most updated guidelines on 2022. But real life, when you look at what happened in sickle cell or hemolytic anemia causing pulmonary hypertension, and you think about the mechanism behind this development, you can see that it really does not belong to one entity. There could be basically chronic thromboembolism there that happen, left ventricular dysfunction and HFpEF, which is not uncommon at all, hypoxia drive, fibrotic lung diseases, etc. So there is more than one reason behind it. And even when you try to classify the disease based on hemodynamics, you can get all kind of pattern. Those who have pure pre-capillary, those who have basically basically capillary, and those who have combined pre and post capillary. So you can get any type, any group, any hemodynamic abnormality when it comes to those patients. But when you try to look carefully and say what really happened, why this is happening when it comes to basically hemolysis and sickle cell disease, and there is no doubt that hemolysis is the main basically trigger for the development of the pulmonary hypertension. And we look at it, what happened normally, nitric oxide, which came from basically arginine, L-arginine, and with the NOS system, nitric oxide stimulate basically enzyme CGC that is basically form the active cyclic GMP, which is the good molecule, the good guy that really inhibit cell proliferation, vasodilatation, prevent platelet aggregation, etc. And the nitric oxide, in a way, maintain the laminar flow, preventing basically stimulation of the endothelial cells by the flowing RBCs. Probably what we see in the congenital heart disease, basically with the shunting, with the shear stress, is that the RBC keep really stimulating the endothelial cells. So nitric oxide in normal situations prevent that, and there's what they call that basically cell-free zone between the endothelium and the flowing basically RBCs. Now, whenever you have hemolysis, now there is a release of multiple basically a component that usually are contained within the RBCs, including free hemoglobin, heme, basically arginase, ADA, etc. And those kind of materials that now we call them collectively as basically DAMs, danger-associated molecular pattern molecules. So these kind of molecules did few things. Basically, arginase, let's say, inhibit the L-arginine, so decrease the production of the nitric oxide, but also ADA, that kind of lead to platelets aggregation and really accumulation, leading to real basically thrombus formation. And then the end result is downregulation of the cyclic glomerulocyclase, basically enzyme, abnormal formation, transferred from the ferrous to the ferric status, making that basically enzyme less active or really downregulated to be stimulated by the nitric oxide. So the mechanism is basically complex. And the end result, although now we don't call that as a group 1 clearly plexiform lesion, there is no doubt that those patients will get vasculopathy. So they get basically, you can see basically thrombogenic activity, smooth muscle hypertrophy, and all of the changes that is similar, if it's not identical, to even group 1 PH. And we know from many studies that during the hemolysis, during the hemolysis attack itself, there will be transient or really acute, basically pulmonary hypertension, even in those patients who do not develop chronic pulmonary hypertension. So those patients, they get acute pulmonary hypertension that settle down after the acute hemolysis improve. And there's kind of clear correlation between the degree of this basic guy. So this was a new study, a New England study trying to look at about 200 patients and trying to look at those patients who have sickle cell with PH compared to sickle cell without PH. And as you can see that those patients, those who have PH with really sickle cell, they really tend to be a bit older than the others. They do have more left atrial and right atrial enlargement, indicating both pre and post capillary component there. They have higher systolic blood pressure. They tend to have basically lower oxygen saturation, more self-reported cardiovascular basically abnormality, and they're more likely to receive basically blood exchange. But not only that, those patients with a pulmonary hypertension and sickle cell, they are more likely to be exercise limited. So basically their 6-minute walk distance is far lower compared to those patients without PH and sickle cell, and their basically oxygen consumption as well is significantly lower. Very interestingly, you look at the fibrotic scarring in the lung in those patients who have sickle cell and pulmonary hypertension, depends on the VQ scan and the HRCT, and you see that those people, they have more abnormal VQ, more abnormal HRCT with a direct basically link with the TR-JIT velocity. So the higher the TR-JIT velocity, the more likely those people, they're gonna have fibrotic scarring, and if you like, a chronic thromboembolic basically featured by the VQ scan, probably most likely because of the fibrosis that can happen in the lung. What about mortality? Yes, definitely. PH with the sickle cell disease significantly increased mortality, and at least in 2 studies, and more studies showing that correlation between echo parameter of TR-JIT velocity and the mortality. So anything more than 2.5 or even 3 of TR-JIT will significantly increase mortality in those patients. Right heart cath definitely is the gold standard, and again, there is strong correlation between the presence of the pulmonary hypertension and mortality, and there's always also correlation between the age of the patient. The older the patient when they get the disease, the more likely that they're gonna die because of the pulmonary hypertension. And when you look at really other predictors of mortality, apart from the pulmonary, basically the measurement with the TR-JIT velocity or the mean pressure, 6-minute walk distance correlate with mortality, basically function class correlate with mortality, and those who have pre-capillary component with increased basically transpulmonary gradient are more likely to die than those who have basically post-capillary pulmonary hypertension. Finally, treatment. How do we treat those patients? There was, as we understand from the disease, that it's mostly related to the nitric oxide. And nitric oxide, basically, really abnormally low nitric oxide in the system, abnormal soluble guanylate cyclase because it is really oxidized. So we thought that treating those patients with nitric oxide maintaining drugs would have a better outcome. So basically the WALK-PHA really study used sildenafil to treat patients with basically pulmonary hypertension and sickle cell disease. So this was a multi-center study, 10 centers from US and UK, basically blinded the patient into either a sildenafil or a placebo for 16 weeks. And the inclusion criteria were those patients with a TR-JIT velocity more than 2.7 and 6-minute walk distance between 150 to 500. Those patients who were on sildenafil, they were really categorized between those who have lower TR-JIT, 2.7 to 2.9, versus those who have more than 3. And of course, basically the primary endpoint was safety and efficacy, looking at the 6-minute walk distance improvement. So after recruiting 74 patients, so that was about 13% from the total really study power, the study was terminated because of the side effect of the drug. So those patients who belong to the sildenafil group, they have severe side effect, which is acute really chest syndrome, an acute hemolytic basically crisis, compared to those patients on placebo. And in those numbers, there was no signal for significant efficacy. So basically, although patient on sildenafil walked 17 meters more, but that was not statistically significant. So at that study, at least, there was no efficacy signal, but there was a safety basically concern. And then people said, why this is happening? I mean, this is nitric oxide-related disease, and now we're giving a drug that really work on that. And I think when we start thinking about it, it actually does make sense. Maybe sildenafil is not the right drug, because we know that those patients, they don't have adequate nitric oxide, so basically their cells are really exhausted. There's a lot of inflammation. The soluble guanylyl cyclase enzyme is down-regulated, so now you are not forming adequate cyclic GMP to preserve. And probably that cyclic GMP that's coming from that system is defective as well. So basically, people start thinking, then why not to start a drug that uses much more proximal to directly stimulate the cyclic GMP irrespective of basically the nitric oxide level. And this was an American study by Dr. Weir and her group looking at 6 Black American, 3 males and 3 females with sickle cell and pulmonary hypertension. And they treated them with riociguat. Those were CTEPH patients, by the way. So they were sickle cell with a CTEPH basically background, and they were not candidate for surgical intervention. So they were treated with riociguat, and they found out there was some signal for better outcome. So those patients, they had improvement in the function class. Their actually TR velocity came down, and the 6-minute walk distance improved in some of those patients. So there was a signal that the drug might be effective in CTEPH with sickle cell, in those patients who cannot go for surgery. So this is our experience in Prince Sultan Military Medical Hospital, looking at patients with sickle cell disease and pulmonary hypertension. So we have 35 patients. 22 of those patients have pure precapillary pulmonary hypertension, and those who are the one that I'm going to really be describing here. So looking at those 22 patients, there were basically median age of about 30 years old. 65 of them were female, all diagnosed by right heart cath. Hemoglobin was about 10. Background therapy, hydroxyurea, and about 80% of them had a regular exchange, 40% of them, and about 20% of them, they were on sildenafil when they were referred to us. We treated those patients with riociguat up to 2.5 milligram TID. 80% were able to reach that dose for 28 months. And when we look at really the outcome between those patients, really basically before and after treatment, there was significant improvement in their function class. So really before treatment, about 80% were function class 3 or 4. Only 16% belonged to function class 2. With treatment, that increased to about 56%. Their 6-minute walk distance improved significantly. Pro-BNP dropped down. There was no significant change in their oxygen. When we look at the echo parameter, there was again significant improvement in the TRG velocity. TAPSE scoring improved. Pericardial effusion that was small, basically and mild in all cases, basically did not change significantly. Hemodynamics, again, showing basically good response in those patients. The right atrial pressure goes down. Of course, you can argue that there was a lot of diuretics basically in those patients. There was more basically exchange, so this might not be only caused by riociguat. Nevertheless, those patients who were on appropriate treatment, they get really better. Their cardiac output improve, mixed venous oxygen saturation get better, and we have the 2 to 3 year basically survival was about 80%. So we believe that there was a good signal that riociguat worked on those patients, and we had no safety concern. Those actually who died, most of them died because of the kidney basically abnormality. So take-home message. I think sickle cell and PH is very, very complex, and I think really classifying that disease into group 5 make a lot of sense because that will allow us to think, or the physician to really think more than really group 1 PH. And we know that what happened during hemolysis, that the release of those basically danger-associated basically materials into the system lead to all the basically pathophysiology of the disease. And we need to understand that those patients, they are more likely to die. They have they have exercise impairment, and they have more fibrotic scarring in the lung. We believe that those patients should be treated mainly with optimizing the care. That's including frequent exchange, basically blood exchange, hydroxyurea, diuresis, and it seemed that riociguat have a signal of real improvement that should be tested in a better way in randomized controlled trial. Data on endothelin receptor antagonist and prostacyclin are lacking and need to be addressed in the future. Thank you very much for your attention.
Thank you, Professor Magdi. Please come here. Okay. Now the last talk in the session will be presented by Dr. Raghda Hussein, which is Chairman of Scientific Committee, Consultant Pulmonology and Pulmonary Hypertension, Assistant Professor King Abdulaziz University, Jeddah, Saudi Arabia. Dr. Raghda will talk connective tissue disease, pulmonary hypertension, risk diagnosis, and clinical phenotypes.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Before I start, I would like to thank Dr. Abdullah Dalan for giving me this huge opportunity to chair the scientific committee this year, under his supervision, of course. And I would like also to thank Mr. Hassan Al-Araini for all of his hard efforts and paying attention to all details. Without you both, SAPH won't be SAPH, and we won't be here today. And thank you so much also for giving me the opportunity to speak today. So I'm going to talk about in the next 20 minutes about CTD-PH. So I'm going to be touching on risk factor, diagnosis, and clinical presentation. So my objectives for this session, I'll start by talking about epidemiology, classification, clinical phenotyping, clinical presentation, risk factor, a little bit about screening, and then risk stratification. So PH associated with CTD is, in the Western country, is the most common cause of PAH after idiopathic PAH. CTD-PH can be seen often with systemic sclerosis, and it can be seen also in lupus and mixed connective tissue disease, and in a less extent in patients with rheumatoid arthritis and inflammatory myositis. Scleroderma and the registries account for more than 75% of CTD-associated pulmonary hypertension cases. So this is the Saudi PH registry. So this is actually the experience for Dr. Abdullah Dalan team in Riyadh. And the reason I brought this today because I want to show the difference. So the population was about 222. And if you look about group 1, majority of them, they have group 1 PH. Idiopathic and hereditary type were about 56 patients, and then followed by actually congenital heart disease. And CTD was actually third. So in Saudi, it's different. CTD actually is the third cause of group 1 PAH. And we can see there is also a large cohort of CTEPH and the Saudi registry. Just one more point about the age of the diagnosis. You can see that the median diagnosis was actually around 30 years old. So, and I think part of that because a large component or large part of the cohort study was actually congenital heart disease. This is the prevalence of PH subtype in connective tissue disease. So different groups, the WHO groups classification, and you can see PH in group 1. The vasculopathy disease is more common in scleroderma and lupus and less in rheumatoid arthritis. Group 2, left side heart disease is more common actually in rheumatoid arthritis, and we can see it in scleroderma. Group 3 related to ILD can be seen on scleroderma ILD, and it can be seen in myositis. Group 4 can be seen more on lupus and antiphospholipid syndrome. So this is only a single center retrospective cohort study was done actually in China, and if you can see group 1 PH here, it was more common in lupus. So CTD-PH were more common in lupus disease in the China population more than systemic sclerosis. This is the REVEAL registry, and you can see that based on the subclassification, scleroderma patient were more than lupus patient causing CTD-PAH. So what we learned from REVEAL, PH is a severe and frequent complication of various types of connective tissue disease, and the prevalence can be variable, but is proved to be associated with the worst prognosis. So classification and clinical phenotype. So this is the hemodynamic classification that we're talking about since the beginning of this conference. So we have the ERS 2022 classification for the hemodynamic. So we have the pre-capillary, the isolated post-capillary, and the combined pre and post when you have both wedge and BVR is elevated. The clinical classification, though, is different. This is a very nice figure. So I'm going to try to show you. So group 1 is basically when they got involvement of the arteriole, and there is no involvement of the venous or the capillary or the capillaries, and this is more common in scleroderma and lupus, and we can see it in mixed connective tissue disease. When you have involvement of the capillary and you have a BVOD-like picture, this can be seen in scleroderma more common. And then we have group 2 disease, which can be seen also in scleroderma and rheumatoid arthritis. Group 3, as I mentioned, in scleroderma and different CTD. And group 4, more common when you have obstruction of the pulmonary artery, seen, this also seen in lupus and specifically on antiphospholipid syndrome. So the clinical presentation, I'll talk first about scleroderma. So the prevalence of PH in large scleroderma cohort was estimated to be between 5 and 12%, but that was the definition of cutoff of 25. When the definition changed to 20, the prevalence actually changed and reclassified to be 10 to 13% of the patient have scleroderma-related pulmonary hypertension or PH. And there was different incidents reported in the French registries. Pulmonary hypertension is frequent and severe complication of scleroderma, and it can be very severe. And PH in scleroderma is actually heterogeneous, and that goes to the heterogeneity of the scleroderma itself. We have scleroderma with limited disease, extensive disease, and we have different mechanisms that can present and overlap in causing the condition. Also, we have other comorbidities and other disease and condition caused by scleroderma, including interstitial lung disease, BVOD, which all can overlap. So making the precise phenotype of the pulmonary hypertension scleroderma patient sometimes can be challenging, and that has to do with the diversity of the mechanisms and the overlapping of the mechanism that can cause the condition. So what are the risk factors to develop scleroderma-related pulmonary arterial hypertension? So if you have the disease for longer duration, more than 5 years, if you are older at the time of the diagnosis, if you have a limited cutaneous disease, if you have profound telangiectasia, if you have a positive anticentromeres and other antibodies with a low DLCO, that's a risk factor for PH. That actually the same thing, just talking about it. So this was actually a review to differentiate between IPH and scleroderma-related PH. And we found that having higher age and a lower DLCO is actually independent risk factor for scleroderma PH. Scleroderma PH have a worse prognosis because they have higher proBNP. They respond less to PH-targeted therapy. This is why they have a poor prognosis, and actually they have poor RV-PA coupling because of the interstitial fibrosis in the RV was seen in the myocardial biopsies. So histopathology is different with scleroderma PAH. They have more small vessels fibrosis, intimal fibrosis, and they have sometimes overlapping BVOD pictures, and they have absence of the classical plexiform lesions that's seen in PAH. This is why DLCO is lower and sometimes can have poor response to PH-targeted therapy. This is just a clinical phenotyping study to assess the survival with different clusters. So the clusters patient with scleroderma-related PH based on presence of ILD. So these cluster 2, they have group 3 because they have severe ILD. Cluster C3 and C1 and C4, they all have group 1. C3 have severe PH, and C1 and C4, they have also, there's just different DLCO. And they looked at the survival. they found that patient with C2, which is basically the red one, which is group 3, is the worst patient of pulmonary hypertension related to scleroderma, and these are the people with more extensive interstitial lung disease. The best prognosis was actually for C4, which is the patient with mild to moderate pulmonary arterial hypertension, limited ILD, and almost normal DLCO. So just a few words on the PH, left heart disease. So scleroderma also can involve the heart, the myocardium, the endocardium, and there is different prevalence of the clinical overt disease that present. Patient also can present with subclinical diastolic dysfunction, and they can have involvement of the myocardium because of the fibrosis. Again, think about it, patient can have risk factor for left heart disease, diabetes, hypertension, obesity, and sleep apnea. And in these patients, CMR actually can detect the condition before it become overt clinically. Myocarditis from systemic sclerosis is different. They have worse fibrosis. This is why they present with worse WHO functional class. They present more with heart failure, and they have poor prognosis compared to other reasons of myocarditis. A few words in left heart disease and pulmonary hypertension, scleroderma, and in HFpEF. So HFpEF also is common. And actually, it's the commonest form. And in some registry, it's up to 20% of patients with scleroderma, left side heart disease, has to do with HFpEF. And if you look, they have worse prognosis than scleroderma-related pulmonary arterial hypertension. And if you look at patients with combined disease, they actually have worse prognosis, and that's because they don't only have the left side heart disease, they also have the intrinsic vascular remodeling, so they need more aggressive monitoring, management, and optimization of other risk factors like hypertension, obesity, diabetes, and left side heart disease. So what's the prognostication factor for survival? It's basically age, WHO functional class, 6-minute, DLCO, presence of pericardial effusions, hemodynamics. And for group 1, being a male patient and having a high right atrial pressure also has to do with the prognostication. So how about lupus? So lupus can be also is frequent to cause CTD-related PH and AGIA. It's less common in the Caucasian. It has been reported to be only 1% of the Caucasian population to have lupus-related PH. It can be also can be caused by various mechanisms. In the French registry, majority of the lupus patients, they have group 1 disease. But again, remember, because of the high prevalence of ABS, antiphospholipid syndrome, we can have also, we have to exclude actually group 4 CTEPH condition. So what are the risk factors if you have lupus? If you have a positive Sjögren antibodies, if you have higher disease activity, if you have positive APL, positive Raynaud phenomena, and positive certain antibodies, you have higher risk developing SLE-PH. SLE-PH patient, they have better survival than scleroderma, and it has reported the mortality 5 years can reach to 68%. In French registry, the 5-year survival for PH lupus was 84%. So they have better survival than the scleroderma PH. And the prognostication for the mortality is the things also we work on, WHO functional class, hemodynamic, they walk less, they have higher proBNP level, and actually they found anti-U1 RMB to be actually a protective predictor of mortality. Okay, we'll move to the MCTD PH. So we know that MCTD PH can have features of scleroderma. Presence of PH is rare, but can be severe and complex disease. They can have group 1 and they can have group 3 if they have an overlapping ILD picture. And the prevalence can be wide and has been described to be up to 24% in tertiary center. However, in some cohort study, it was estimated to be 2%. So what are the risk factors if you have MCTD to develop PH? Having pericarditis, polyarthritis, thrombocytopenia, presence of ILD, and presence of positive anti-Smith antibody. Survival is estimated to be up in 10 years up to 56%, though they are similar to other connective tissue disease-related PH, and they found tobacco exposure to be an independent factor for predictive of mortality. So I'll move to the screening and early diagnosis. So first, why do we think screening is important? I think this can explain it. So we know that to still have a long journey between the patient presented with the first symptoms of PH and between the patient actually being referred to the PH center to get the right heart cath. This can last up to 3 years. This is why the screening method has been advised for patients with high-risk group, especially CTD and scleroderma patient. This is a very nice figure showing, patient actually was 2 cohort. This one is the one that patient with scleroderma, and they looked at the pulmonary arterial hypertension by the detection. So they looked for patients who are asymptomatic, cath them and diagnosed them. And this is actually the routine way. And they found that patients who were established or who were diagnosed based on the detection by screening programs, they actually did better in terms of survival. And the reason why, because we detect them early with less severe hemodynamic, and we start the treatment early, and they will have favorable response. When it comes about which investigation you order for patient with CTD, I will advise you not just to focus. Of course, echo or TTE is still the screening method, but you should consider doing other investigation and not just focus on the echo. For example, getting the BFT, the DLCO. If you have a scleroderma patient have very low DLCO, less than 45%, please suspect BVOD or overlapping ILD picture. Also, presence of high biomarkers like proBNP in a scleroderma patient. ECG can help, and cardiac MR. When it comes to the walk test, 6-minute walk distance is helpful. However, sometimes it's not just representative of underlying pulmonary hypertension, because they can have multifactorial reason why they're not walking. It could be related to musculoskeletal causes, could be related to the left side heart disease, or could be related to the underlying ILD. So what do? We use the echocardiogram, and this is basically the ECS-ERS guidelines about the screening by echo and assigning probability by using the echo for the intermediate high risk, and also looking for the other features of pulmonary hypertension in the echo, including the right ventricle, the IVC, and the pulmonary artery dilatation. So when would you do the cath? When would you refer your patient to the cardiology to do the right heart cath? So that is challenging. There is no clear criteria or concise criteria. However, multiple strategies have been advised or have been shared. The one that actually, the algorithm that we're using is the DETECT algorithm, and this more toward the rheumatologist. So this is actually by using certain conciliation of clinical symptoms and investigation, and then it will tell you when to refer the patient to the echo, and then from the echo you will use other features, and then you will decide about sending the patient to the right heart cath. So what does the guidelines tell you? In patients with scleroderma, you should annually evaluate the risk of PEH. That is class 1 recommendation. And if your patient has scleroderma for more than 3 years and the DLCO is less than 60% and the vital capacity is more than 40, it's very recommended to use the DETECT algorithm in order to send these people to the right heart cath earlier. If your patient is symptomatic and still have an unexplained dyspnea, please don't stop. Consider exercise testing, echo, CPET, and referring these patients to the right heart cath. Also, assessing the risk is not only by doing the TTE. We need to look at other features, BFT, DLCO, 6-minute, and biomarkers like proBNP. Policies should be actually be there in hospital in order to increase the screening method and also the early detection for patients who are asymptomatic or even have early symptoms to detect the disease early, because we know if you get them early, you diagnose them early, they have favorable hemodynamic, you start them in treatment so they respond better. Risk stratification. So at diagnosis, we use the 3 strata model to risk stratification at the beginning of the diagnosis, and then based on that, we decide what kind of PH targeted therapy you will start, dual therapy, triple therapy. And on follow-up, we use the 4 strata model where we can adjust the treatment therapy at 3 months. So, take-home message: PAH associated with connective tissue disease in the Western countries is the second most cause for pulmonary hypertension after idiopathic PAH, and it's actually associated with worse prognosis and worse response to PH targeted therapy. CTD-PH most often seen as scleroderma, lupus, MCTD with the scleroderma feature, rarely seen in other connective tissue disease like rheumatoid arthritis and inflammatory myositis. And current guidelines still recommend evaluation of the risk annually for patients with scleroderma for pulmonary arterial hypertension, even if the patient is asymptomatic. However, this is not the case for other CTD. For other CTD, to assess the risk of PH, usually only when the patient is symptomatic. However, I will advise you to be more thorough into getting the right investigation for earlier diagnosis. With this, I will conclude my talk, and thank you so much for your attention.
Thanks a lot, Dr. Rad. Can you join us? Okay. The session is open for discussion. I'll start with one question for Luke Vishiri. What is the most appropriate for diagnosing pulmonary arterial hypertension? Pre-capillary pulmonary hypertension. Is it pulmonary artery wedge pressure or left ventricle end diastolic, and why?
Thank you, Mustafa. This is a very important question, of course. The way I would put it is that if you stick to the hemodynamic phenotyping, if you have a correct wedge pressure, and some colleagues, especially in the US, are drawing an oxygen saturation after inflating the balloon to confirm that you're really in the wedge position, I think that's good. Because again, the wedge pressure is what the pulmonary circulation sees. So. And not the LVDP. LVDP is important, however, if you want to make a hemodynamic diagnosis of heart failure with preserved ejection fraction, and what we would rather do is add the provocative testing on top of the resting measurements. So I think it goes both ways. If you have good and appropriate pressure traces, wedge is good, but always put that in the global context, because you cannot disconnect completely the hemodynamics from the clinical situation, clinical status.
Thanks for the speakers. I enjoyed all of your talks. Jean-Luc, this concept of having isolated left atrial failure, I like it, because this is what we see many times in the real life practice. So we see these patients with only left atrial dilatation, no HFpEF, no HFrEF, mitral valve is good, and of course they have pulmonary hypertension. So the question is, two questions. One, it makes, from superficial thinking way, no sense that the mechanism of development of precapillary pulmonary hypertension will be different from having HFpEF, for example. Because, again, backflow of the fluids and the passive reactive changes in the future. So what you really think is, do you really think the mechanism will be really different, developing precapillary changes, some remodeling with time, if you have only left atrial dilatation? And the second question, and I know we're coming to the World Symposium, would you think also there would be some rule in the future for pulmonary arterial hypertension medications in this particular subgroup of patients with left heart disease?
Thank you, Abdallah. Do we have an hour? Because that's really tricky. I do agree with you. This left atrial dilation that sometimes can happen in isolation is probably one of the mechanisms that would drive all the process upstream. Yeah. It's difficult to tease out, however, the role of an isolated phenomenon to develop all the mayhem of changes in the remodeling process, because what makes the biggest distinction between group 2 and group 1 is the fact that you have capillaries and venular involvement in the histology. So to have that, either you need to have some sort of genetic predisposition or a downstream problem, or you need to have indeed group 2 pulmonary hypertension and HFpEF. Again, one of the ways to tease that out, I mean, from the surface as a clinician, is to stress the left atrium. And stressing the left atrium means exercising or fluid loading test. That's something that can happen. I would add something I didn't touch upon because it's already a bit premature, but it seems that when you look at the function of the left atrium by the new echocardiography, it means like the strain of the left atrium, you see abnormalities even in patients who have PAH. So it seems that there's a disease of both atria in patients with pulmonary arterial hypertension. There's more insult on the right side than on the left side, but the left atrial function is not completely normal by echocardiography, even in PH. So that's why it's getting more and more complex to tease out the main differences. Now, on the World Symposium, there's not a lot I can disclose at this stage because it's still work in progress. But I mean, I think we will come up with proposals, for harmonization of definitions, and we need to talk to the other task forces to be sure that we are on the right track and we don't completely derail. And second, also recommendation for doing pragmatic trials, because it is remaining an entity. And I was struck to see that in your registry you have a lot of CHD patients. And those complex CHD, unless you have a simple ASD, and my colleagues from the congenital heart disease side are always saying that there's no such thing as a simple ASD, it's more complex than that. You also have left ventricular insult in CHD population. And then I think there's also a sense to address the question of therapies in those cases.
Thank you. One more quick question to Regina. So the reason we put this talk in our program is the fact that many patients are asking about this potential mode of treatment, given the fact that it's more convenient to them. So we have one patient, as you probably know, that she comes every 20 days, have her pump fueled and go. It's like going to a gas station, having gas and going home. And but it did not get a popular presence as a mode of treatment elsewhere in the world. So, and the same patient 3 years ago, she came to us with an emergency worsening, and we found that the tunneled tube was actually kinked. So we salvaged the situation and everything was changed later on. So do you think if there is an improvement in technology, and now I know the permission and the certificate has expired and it's not renewed, but with the development of technology, this mode of this route, acceptable route, preferable route for patient would be one day an approved one in the future?
I think that would be an approved way in the future. There have to be more information how the line has to go, the route of the line to the body, that the kinking is avoided, for example. And there should be also one feature that if you have a kinking in the line, that you can get the medication before the kinking. So when the alarm is triggered, that a needle goes out, for example, and brings the medication to sub-Q. If this is done, I guess it will be a good feature for all patients.
Thank you for the speakers. Actually, I have a question for Prof. Bashiri. So how would you explain that Vericiguat did work in HFrEF patients in group 2?
So if you look at the results of the dynamic study, what it mainly shows is that the primary endpoint was met. The primary endpoint was a change in cardiac output. So there was an increase in cardiac output. However, if you look at the benefit in the other, on the other endpoints, there was no difference. There was no change in NT-proBNP, no change in exercise capacity, no change overall in pulmonary vascular resistance or mean atrial pressure. There was no change in the event rate. So you probably have, and that's my take, you have a true systemic vasodilatory effect. Now, because the group of patients it was a significant group of patients, there was a subset with really high PVR, and that group seemed to respond even better with a greater decrease in PVR. So I think it's mostly systemic vasodilation. What worried me in the trial is that there was a lot of patients having to stop the treatment because of side effects in the treated group. And that's something we see also in the other trials on group 2 PH. So we need to be watchful because we're touching to a very different, probably a quite different disease than the common.
Thank you. Doctora.
Thank you everyone for the great presentation. Fatma Hadi from Kuwait, advanced heart failure and PH cardiologist. My question is to Jean-Luc. Regarding those patients with combined pre and post capillary pulmonary hypertension, we know when the patient has a closed diastolic gradient, it's easy. We just unload the left ventricle, unload the left ventricle. We'll just improve the left-sided loading conditions. But once there is very big diastolic and systolic pulmonary gradient, here we think where there is a coexistent PAH or no. And if there is any role of genomics now to this thing, because probably maybe there is a combined genes for HFpEF or restrictive cardiomyopathy and PAH, where those patients, they derive the most benefit from PAH-specific therapy. Thank you.
Thank you very much for your question. You're absolutely right. There is clearly a genetic predisposition. I mean, not all patients develop CPCPH. It cannot be just the effect of the environment. There must be something different. A couple of groups have worked on that. I think Fayaz was the first author and the first one to show that there is a difference in the genomics. We had one case of really severe CPCPH with decreased ejection fraction who had the BMPR2 mutation. We do not know whether that triggered the disease or not, but there is surely a common ground. Now, current work is looking at, as you mentioned, the genomics, but also proteinomics and metabolomics of the disease, because we're getting a little bit out of the cath lab to go more to the pathophysiological, pathobiological signature of the disease. There's another, I don't want to be too long, the PVDomics initiative in the US is going to give us a lot of information about those differences within the different categories.
Sorry, just one more follow-up question. Do you think if we have very high suspicion that PAH is there, anyone can just start PAH-specific therapy in hospital and monitor for the need to increase furosemide or diuresis in that patient? Is there any justification to keep the patient for a bit of prolonged period to know what are we doing in case we decided to treat PAH?
I don't know that. I don't know if there's a safety margin. If you look at the side effects under treatment, it's not necessarily coming in a short period of time. But to come back to your first comment, yes, if you unload the heart, that's the goal in all patients with heart failure.
Thank you, sir.
So last two questions, Dr. Farqali.
Thank you for the all speakers. Actually, I will add to the question of my colleague, Dr. Mustafa. What precaution you think we need to take during the right heart cath evaluation, especially in a diverse group like the connective tissue disorders? These people might have diuretics before, so as you said, you prefer to have the left end-diastolic pressure measured. Do you think we need to exercise them or to saline a challenge in order to pick up these unique groups with their atypical IPF, or HFpEF? So do you think we need to exercise all the people?
I wouldn't say we need to exercise everyone, because in some cases it's so obvious. I mean, obvious. By the way, in the way that you have such a burden of history leading to left heart disease as a cause. I mean, having left heart disease as a cause of pulmonary hypertension, you don't necessarily need to exercise those patients. I think you need to probably exercise or do a stress in patients who have a moderate increase in wedge, surely in the gray zone between, I mean, we know that 12 is the normal value, right? So let's keep it at 15, because otherwise we're going to totally messed up in our heads. But the 12 to 15 at our center, if you have a burden of comorbidities, and come back in July to see what we will propose on that. If you have a significant burden of comorbidities, do exercise those patients. And if you have an increase in wedge, one of the important things is that you do not know whether those patients truly have pure HFpEF as a cause of pulmonary hypertension or have a trait associated with it, and that's the PH with comorbidity. And we do not know the response to treatment.
Yeah. But my question for Magdi, it's a small question. Again, sotatercept has proved to be of benefit in hematological disorders. So do you think this drug needs to be investigated as a first line in treatment of this group, specific group of PH associated with hematological dyscrasis and disorders?
I think this is a very good question. I have very simple answer. I don't know. I have no idea. I think, whether you're going to use sotatercept in those patients who have hemolytic anemia and whether that's going to make any impact because of the side effect profile of the drug, to be honest, I don't know. I'm not aware of any studies that was directed to use sotatercept in those group of patients. I think in my perspective, when we see those patients, I think frequent exchange transfusion is the most important things that those patients they have. I think basically hemoglobin S should really drop less than 30%. And by doing that, you achieved about basically 60-70% of your goals. I think most people who have severe pulmonary hypertension, they do have chronically basically hemolysis, not adequate exchange. Hemoglobin S is in the 60-70%, so that's a problem. But to answer your question, it's a good thought, but I don't know the answer to this.
Professor Tbon,
thank you, Majid. That I would like to point out that the chronic blood exchange transfusion is probably the most important option in those patients. And maybe it's not a matter of drugs. It's maybe, as you're right, you have to treat the cause of pulmonary hypertension. Thank you very much.
Can I just have one question to Raghda? Sorry.
To you.
Oh, good.
Just talk twice.
Okay, so Raghda, because when you did talk about that basically in Abdullah data and actually in our data as well, that really in basic PAH group, CTDs is not the second most common cause in Saudi. It really come after the congenital heart disease. I think there was here referral bias because I don't think that this is really true. Because when you reported our data back on 2014, rheumatologists were not involved with us at all. And we used to have very, very minimal referral from hematology, from rheumatologists. Nowadays, I think if you look for the last 3 to 4 days, most of our cases are either idiopathic or CTD related. Congenital heart disease is still there, but it came down. So do you think that this referral bias is the problem?
In my center, we don't see a lot of congenital heart disease. They don't get referred to me, so we don't have this strategy. So basically, majority of my patient is IPH and CTD. So it could be a referral bias. So my question to you, just a quick question. Do you use riociguat in thalassemia, not just in sickler patient? And no, yes or no, and why?
We do have 2 patients with thalassemia. We did not treat them. We are, as a matter of fact, again, I totally agree with Basic Olivier. I think those patients with chronic hemolysis, I think if you optimize the basic transfusion, watch their hemoglobin S, they're fine. Most of them. I'm not saying all of them, but most of them. All of them, they get acute PH during the attacks, but then they settle down, most of them. But no, I don't have an experience with that.
Thank you.
So thank you for the speakers. It was really amazing and interesting session. So we will return back exactly at 10:55. Thank you.
Nice to meet you. Great talk. Thank you.
Is that working? You can hear me well? Perfect.
Good morning, everyone. Let's get started here. This session 7 about CTEPH. I'm Dr. Badr al-Zahrani. I'm an interventional cardiologist at Princeton Cardiac Center. And I have Professor Ahmed Farghali, who's the director of the PH program at Armed Forces Specialized Hospital in Cairo, Egypt. For the sake of time, we're going to get started. And by the way, there is a 6-minute workshop started in the same time with our session. If someone is interested across the hall, we're going to go ahead and introduce the first speaker. Go ahead, Professor Ahmed.
Thank you, Professor Zahrani. It's my pleasure to co-chair this session with you. And actually, I'm honored to introduce the first speaker, Professor Sanjay Mihatta. Professor Sanjay Mihatta is Medical Director, Southwest Ontario Pulmonary Hypertension Clinic, London Health Sciences Centre, Ontario, Canada. He's going to deliver for us the talk. Actually, it's very interesting. He's going to start the journey, starting from the PE to CTEPH. I believe this is going to be very stimulating to know how the journey starts and how it ends and who is at risk.
Thank you very kindly. Good morning, colleagues, friends. Lovely to join you here. All good? Perfect, thank you. And a very warm welcome to my former fellows that you might know. You've heard already this morning from Ragda Arif and also Fahad Al-Afi. Wonderful to see them being both successful in their own practices and of course happy in life as well. So very happy to be here and join you all. Many thanks, Professor Al-Dalan, for the kind invitation and also the challenge, because this, I think, is a very interesting topic and it'll set the morning off in terms of our discussion of CTEPH. So the task I have is to help us understand the journey from acute pulmonary embolism, evolution to chronic pulmonary emboli, and CTEPH. Those are my disclosures, none of which are relevant to my presentation this morning. So all of us clinicians know this disease. We've been looking after pulmonary emboli for many years. It's obviously a common disease, 1 in 1,000 people every year, and so estimated 7 to 8 million cases a year in the world. And I heard the Saudi population is 30 million, so that means 30,000 patients here every year will have pulmonary embolism. This is not a simple disease. It's still often a very serious and fatal disease, as you all know. 3rd leading cause of cardiovascular death, as well 10% early case fatality, and up to 1 in 4 of our patients won't survive the year. It also, as you know, is underdiagnosed, and so I think these numbers underestimate the burden that patients face. So let's understand the evolution. So thrombosis. As some of you know, when you're sitting for prolonged periods, like flying here from North America, little clots are starting to form in your leg circulation. But fortunately, our body has mechanisms to break down those clots. They don't become major DVT and definitely not pulmonary emboli. Clearly, if that progresses, then you end up with a very significant thrombus, loss of patency of the vessel. So that happens all the time. The question is, how does that then become chronic? Well, we have mechanisms to break down those clots. Very importantly, in thrombus resolution, there's early phase events and late phase events. Early is straightforward, it's fibrinolysis. The late phase events are actually more interesting pathologically, I believe, in CTEPH. So let's talk about those. If there's excessive thrombosis or prolonged thrombosis, fairly simply, it's one of 2 major possibilities. Did you have a problem of enhanced or abnormal thrombosis, or is a problem with resolution of the thrombus? And so both of those are possible in CTEPH and chronic PE. The first part, the thrombosis being abnormal or enhanced, I'm going to downplay that. There isn't a lot of evidence to suggest it's that abnormal in patients with CTEPH compared to other patients with PE. We all know that recurrent PE is a risk factor for CTEPH, clearly, and yet not all patients with CTEPH have to have had recurrent PE. As well, there's been this fascinating idea over the years about thrombosis in situ in the pulmonary circulation, whether it can start there or once you have a small PE, whether it can grow there. There again is not a lot of data to support that, so I think it's unlikely a major mechanism in our patients. Much more important is this idea of incomplete thrombus resolution. And there's 2 aspects to that. We talked about fibrinolysis being important. We talked about the healing response to the clot, so both of those could be disturbed. Let's look at some of those examples. So a long time ago, our friends in San Diego, of course, with their tremendous work in SAPH, did identify that there could be a basic abnormality in thrombolysis. And they did this looking at 33 of their SAPH patients, detailed proteomic and genomic analyses of their fibrinogen. And what they identified in 33 patients is 5 of them had a dysfibrinogenemia, functionally abnormal, but also genetically abnormal. Let me give you an example of the data, very interestingly. These are what's called turbidimetric clot lysis curves. Essentially, you take the fibrinogen, you clot it in vitro, then you try to break it down. And so if you look at these normal curves, the dotted lines, that's the breakdown of clot into soluble fragments. The solid lines are the patients, the 5 of them. What you see is it's impaired in terms of clot breakdown in vitro. So clearly the fibrinogen is abnormal in function. As well, they went further and said, where can we find the defect in the fibrinogen? And all of those 5 variants, they identified amino acid abnormalities related to genetic abnormalities. So clearly, this is a potential cause of SAPH in a small number of patients, an abnormal fibrinogen. Interestingly, the 5 variants they found, they labeled them San Diego 1 to 5. I guess that's okay, they're allowed to do that. More recently, there's been more genetic work looking at potential novel genetic variants in the fibrinolytic pathways, and this is work from Japan. In their 51 patients, what they found was 7 of them had a genotype mutation in thrombomodulin. And many of you know thrombomodulin, perhaps better than I, it downregulates thrombosis. And yet, if they had this TT genotype versus the typical CC and also CT genotypes, what they found was if they looked at a molecule called TAFI, thrombin-activated fibrinolysis inhibitor, the levels were the same across the genotypes. However, in patients that had the TT genotype, what you see is they had higher levels of activated TAFI. Now that's important because TAFI is a fibrinolysis inhibitor. So again, you're impairing the normal fibrinolytic response. So to summarize the fibrinolysis, there's 3 abnormalities that clearly have been described. I didn't tell you about Pi1, but that's well known as well, but a dysfibrinogenemia and then increased activated TAFI. So very important. That's the early response to thrombus. What about the healing response that comes later? This is fascinating, and I learned a lot thanks to Professor Al-Dalan. Early response, easy. Platelets are in there, fibrinolytic response. Neutrophils also come in very quickly and they cause inflammation and necrosis and try to destroy the clot. However, the later response, typically after 7 days, in the work that's been done in the peripheral veins, not a lot of work directly in the lung circulation, but we're extrapolating. In the later responses, what are more important are the chronic inflammatory cells, macrophages and monocytes, as well as fibroblasts, and then very importantly, differentiated myofibroblasts, as well as stem cells, mesenchymal stem cells from the bone marrow infiltrate and play a role. And then clearly there's deposition of collagen, driven in part by growth factors that we heard about beautifully the last 2 days, VEGF, as well as basic fibroblast growth factor. And then really important, you've lost the endothelium where there's been clot, and that has to re-endothelialize to, again, restore vascular patency. So re-endothelialization depends on endothelial cells. As well, in the clot and scar tissue, what you see are neovascularization, so new little blood vessels that have to form to help resorb this. And that, of course, depends on endothelial cells, local endothelial cells, but also bone marrow-derived Tie2 cells, thought to be endothelial progenitor cells. So what's happening to all of that cell-wise in our patients with SAPH? This is a fascinating study from Beijing a couple of years ago. They took patients undergoing SAPH PEA and looked at the specimens that came out and did this fantastic landscape atlas of the cellular distribution in those endarterectomy samples through single-cell RNA sequencing. Beautiful work. In brief, if you take that material and create a single-cell suspension, you can obviously analyze all the expressed genes, all the messenger RNA, reverse transcribe it, and then look at the genetic profile on the right. Let me blow that up for you. And what you get is, depending on the different genetic markers, different populations of cells. And they identified 16 clusters based on the genotyping. They went forward and said, how can we identify the cells? Well, let's use some well-known marker genes for all the different cells we think might be involved. And what they identified is, on the left side, each of those areas, the different cells that likely were involved. So, for example, endothelial cells here, a small population, a large population overlapping fibroblasts, and smooth muscle cells. If I break that down for you, what you see in the green on the right side is the vast majority of cells, almost 40%, are fibroblasts and smooth muscle cells. A tiny number, 2% endothelial cells, and lots of other cells that are inflammatory or involved in the repair process. For example, stem cells, cancer-related stem cells, interestingly enough. So what are those cells doing? This is one of the examples to show you the gene ontology, how they characterize them, using these 9 markers that was able to differentiate fibroblasts and smooth muscle cells. They have beautiful diagrams for all the different cells they characterize. So there's too many abnormal cells in there, especially muscle fibroblasts. So what's happening in the actual healing process? First of all, that neovascularization, the angiogenesis, that is not working. And this is a lovely study from many years ago. In fact, one of the co-authors, Professor Irene Lang, is with us this morning. We'll be chatting with us shortly. And they did something very simple and very elegant. They started with the fact that we all know that endarterectomy samples, there's white clot and there's red clot. You see on the right side the difference. The white tends to be more fibrotic, the red more fresh thrombus. And they said, let's look at the different levels of vascularity in those different types of clot compared to normal pulmonary arteries from the same patients. And so compared to the pulmonary arteries where there's no clot, you see beautiful vascular channels. You lose those in both the red clot and the white clot. As well, if you actually stain for endothelial cells using both VWF and PCAM, you can see a dramatic reduction in both of those compared to vessels in the same patients where they didn't have thrombosis. So clearly less endothelial cells, less vascularity. As well, they went further and said, let's stain for all the normal factors that promote angiogenesis. So you can see the list there, angiopoietins, PCAM, CDH5. I want to focus on one of those, KDR. And KDR is very important. You all know the role of VEGF, vascular endothelial cell growth factor. It promotes endothelial cell proliferation, migration, and survival, all of those essential to angiogenesis. KDR is VEGF receptor 2, so that's how VEGF works. And in their mouse model, what they showed was if they induce venous thrombosis on the bottom in the controls, what you see is significant clot on day 3, and then over 28 days, there's marked resolution of the clot. But if you knock down or knock out KDR conditionally, compared to day 3, very little resolution of clot. So clearly the KDR is impairing the VEGF response that's essential for the angiogenesis for thrombus resolution. So KDR is important. What about other potential genes that are involved? This is a lovely study just this past year. I'm really surprised Dr. Gain didn't present this study in his review of the year. The angiogenic gene profile of, again, PEA specimens. So a fascinating study. Again, Professor Lang. Small study, 8 subjects. And what they did was divide them up. You can see on the right side, group 1, the much more severe hemodynamics, PVRs over 1,000. On the right side, less severe. And then they did, again, RT-PCR, gene profiling of all the angiogenic genes, 84 of them that they thought were important. They generated this diagram, which is called a cluster map or a heat map, and they can start to then look at individual gene expression changes between the severe patients and the less severe patients. And so in brief, what you see is many genes in the middle of this diagram are expressed similarly between the more severe and less severe patients, but there is a small number of genes that are overexpressed and a large number of genes for angiogenesis that are underexpressed, so clearly suggesting impaired angiogenesis. A lot more work coming to understand what genes those are and perhaps how to intervene. So the question is, when you have impaired angiogenesis, what's wrong with the endothelial cells? Are they abnormal, like perhaps in PAH, or are they just responding to their local environment? And we believe the latter is more likely, that there's factors present in the clot, in the organization, the fibrosis, that's actually impairing endothelial function. And this is a lovely study that helps us understand this, again with Dr. Lang's work. Angiostatic factors. So if you look at PEA samples, 8 patients, small study, and they found in the PEA samples, as well as if you take those samples and culture them, the fluid above the culture, the supernatant, you find higher levels of several factors, including, on the right side, PF4, which is a ligand for CXC chemokine receptors, IP10, a very important cytokine-activated fibrotic mediator, and collagen. So they found those in the tissues, and here you can see they're also present in the supernatant. So there's more of these factors in there. So what are they doing? Well, in beautiful work going forward, they said, let's take normal endothelial cells, and these are probably the best model for CTEPH patients, human pulmonary artery endothelial cells, and you can see they culture them here. This is what they normally look like, a nice monolayer. If you then injure them, this is a very common thing, you take a glass rod and you scrape them. As you generate this little wound, within 36 hours, that heals. Endothelial cells proliferate, migrate, and seal up the defect. However, if you take those same endothelial cells and apply collagen, if you apply collagen or PF4, you markedly inhibit that repair response. You can see it hasn't repaired here. And even more striking, if you measure endothelial cell proliferation on the bottom right, what you see is you've impaired endothelial cell responses. So they can't proliferate and they can't repair the induced injury. Even more exciting, if you culture those same cells in what's called matrigel, a gel matrix, normal endothelial cells are amazing. They start to form little capillary tubes, a beautiful network, very much like in our alveoli. Again, if you apply IP10, PF4, or collagen, you can see you greatly impair that normal vascularization and the creation of capillary tubes, quantified down here. So clearly the factors in the PEA material in our patients is impairing their endothelial cells from doing what they normally do, which is neovascularization. Let's look at the pathology of CTEPH to understand what else might be going on. And this is a beautiful diagram from our colleagues Gallier and Kim many years ago. We all know, of course, that there's thrombus in the large elastic arteries, but what about the distal part of the microcirculation? There's obviously important differences in areas that are obstructed. These are hypoperfused regions of the vasculature. Areas that are not obstructed are actually often hyperperfused, more perfusion. And yet, interestingly, the pathology seems to be similar in those two areas. The diagram is actually much better in the European statement. And what you see is this is the spectrum of the pathologic abnormalities. So there are arterial lesions, most commonly. The small muscular arteries get much thicker, both because of intimal fibrosis as well as medial fibromuscular remodeling. Amazingly enough, very similar to PAH and the related venous diseases, you see fibrosis and obliteration of veins sometimes, and you even see some proliferation of capillaries in our CTEPH patients. So it's a very complex pathology. Of course, we also see classically thrombotic lesions with recanalization. Now, this spectrum of pathology explains, very importantly, some of the pulmonary hypertension and elevated PVR in our patients, which is clearly dual-faceted. The clot in the major arteries, of course, very important in the elastic arteries, but that's only a part of it. Clearly, the microvascular angiopathy is also a contributor to the pulmonary hypertension, especially in the tiny vessels, less than 0.5 millimeter or 500 microns. And it's very much like PAH, multiple levels of vascular remodeling, arterial, capillary, and venous. And we looked at all those changes in the previous slide. Now, this is so important because all of you as clinicians like myself know that our patients have different features of both of these, some of the large vessel thrombosis and some of the microvascular. And it's so critical to understand that, even though we don't have pathology in our patients, through imaging, trying to understand that to decide what treatment is best. Clearly, if there's large vessel disease, I'm thinking about endarterectomy or BPA. If there's more microvascular, I'm thinking medical therapy, and Professor Lang will do a much better job than I could explaining multimodality therapy. So back to the microangiopathy. There is clinical evidence, and all of us recognize this. We know that a small proportion of CTEPH patients, up to a third, clearly are, quotes, inoperable. The degree of thrombosis that you see on imaging doesn't explain the severity of the pH or elevated PVR. As well, in those patients, even if you do PEA, the outcomes are not fantastic because there is that likely microvascular angiopathy. And then we know that even after successful PEA, on average, 20% have residual pH, and that is important because it's suggestive of the angiopathy, and it's very important prognostically in terms of post-PEA survival, short-term in the first month, but also long-term survival. So what about the pathobiology of that microangiopathy? How does it develop? The sense is quite interesting. It's hemodynamic, and that's because if you have obstructed segments, blood flow doesn't stop in the lungs, it redistributes to other areas. So this idea of hypo and hyperperfused segments of the lung, and vascularity. And the microangiopathy, amazingly, is observed in both of those areas and is very similar, whether they're hypo or hyperperfused. It is thought to be largely shear stress and increased flow from systemic to pulmonary collaterals and anastomoses that you and I all have, and that also can develop in the situation of CTEPH, which we all know from bronchial artery CT imaging. And these are from the bronchial arteries into the vasa vasorum, which feeds my airways, and then into the capillaries and the pulmonary veins. So it makes sense there's pathology all through the circuit, from arterial to capillary to venous. And then, not surprisingly, with all those vascular changes, shear stresses, endothelial dysfunction becomes an important player. Nitric oxide deficiency, excess endothelin has been described, and of course the growth factors that we learned about beautifully the last 2 days, driving all the remodeling. So to summarize the journey from pulmonary embolism to chronic PE and CTEPH, it's obviously quite complex pathobiology, multifactorial mechanisms. Like I said, thrombosis being abnormal and hence is a small part of it. Much more important is this exciting lack of thrombus resolution, and it is both impaired fibrinolysis in some patients, different pathways, but even more so this repair mechanism gone awry, not working properly. And then, not surprising in the vasculature, endothelial cell dysfunction is critical to microangiopathy. It is largely due to systemic artery to pulmonary artery anastomoses, and even though it's like PAH, we think it's different. There doesn't seem to be a primary abnormality of the endothelial cells like in PAH. It's more a response to the environment. And lots of contributing factors that are trying to be integrated into this model, classically infection, inflammation, autoimmunity, and genetics. There's data that I've shown you. And then very exciting, looking forward, like Professor Yu showed us, the genomics of understanding the responses of individual patients is very exciting. Thank you kindly.
Thank you so much, Professor Mehta, for the excellent presentation. It is indeed a very complex pathology and journey. For the sake of time, we'll leave the questions till the end. We're going to introduce the second speaker, Professor Jansa. Professor Jansa is the head of Center of Pulmonary Hypertension at the Charles University and General Hospital of Prague. Looking forward for your talk. He's going to talk about CTEPH risk stratification.
Good morning, Mr. Chairman, ladies and gentlemen. First of all, thanks to organizers for inviting me. And my topic is risk stratification in patients with chronic thromboembolic pulmonary hypertension. So those are my disclosures. And I would start with the definition or description of what is the risk stratification. The risk stratification is it is one possible description that it is a technique for systematically categorizing patients based on their health status and other factors. It is very important to allocate the therapy based on the risk stratification and also the prophylaxis. And of course, it could reduce the cost for the treatment, and the treatment based on the risk stratification is more pragmatic. Probably the first use of the risk stratification is coming from the famous publication of the Previngen cohort, and this is the derivation of the risk stratification for the risk of cardiovascular comorbidities. When we look into the guidelines for pulmonary hypertension, for the group 1, pulmonary arterial hypertension, so we can see that the therapeutic algorithm is driven by the risk stratification. We can see a very sophisticated model based on many parameters describing the clinical status, describing the functional capacity, and of course function of the right ventricle. And based on the risk stratification, we are able to categorize the patients and correctly treat them at the time of diagnosis, and of course also during the follow-up. If you look in the chapter dedicated to thromboembolic pulmonary hypertension, we can see that the therapeutic algorithm is quite different. We can see that the first is the categorization of the patient as operable and not operable. And for operable patients, the treatment of choice is surgery. So I will start with the risk stratification of operable patients. The untreated thromboembolic pulmonary hypertension is a devastating disease. Those are the data more than 50 years ago coming from the Czech Republic showing that long-term outcome of patients without specific therapy for thromboembolic pulmonary hypertension with mean pulmonary artery pressure higher than 50 millimeters of mercury is extremely poor, so long-term survival 5 years is only 10 to 15%. And surgical therapy is completely changing the life of patients and completely changing the long-term outcome. Those are the data from the first international registry describing very good outcome of patients after the surgery when compared with inoperable patients. So this is a very critical part of the first step if the patient is operable or inoperable. And our target is to significantly improve hemodynamics, improve the survival, and treat the pulmonary vessels. So there is not any specific category for the high, intermediate, or low risk. And we are deciding based on the imaging, which is very important. So we need very good radiologists. We are deciding based on the surgical experience. So we need the significant experience. So we should have a long-term learning curve. And of course, based patient factors. So again, we can see that there is not any risk stratification, and critical for the decision if the patient is operable or not is multidisciplinary team, and part of the team is experienced surgeon, PA specialist, BPA specialist, radiologist, and from time to time anesthesiologist. We can see that there are different specimens from different levels of pulmonary arteries, and despite there is not any risk stratification. So we can see that there is one modifying factor which can increase the risk of the surgery, even if the patient is classically operable with the proximal disease. The other data many years ago from San Diego showing that patients with very severe pulmonary vascular resistance and pulmonary artery pressure are associated with higher risk of mortality and higher risk of residual pulmonary hypertension. Currently, we are able to treat residual pulmonary hypertension, but still very severe hemodynamics is the risk factors, which is confirmed by many publications. For example, in this publication from the French Center, we can see that the patients with severe hemodynamics, PVR higher than 800 dynes before the surgery is associated with the worst outcome than the long-term outcome of patients with PVR below 400 dynes. So this is the reason why, despite there is not any risk stratification, we can stratify those patients based on hemodynamic condition to patients with high risk and low risk. And there is a lot of publications from different centers in the past that it is reasonable to decrease the pressures and PVR in patients with extremely high pulmonary vascular resistance. There is not clear cutoff or threshold, but in many centers, 1,000 dynes is accepted. So this is one example from my center. So currently we are using the strategy that if the patient is with very severe hemodynamics, PVR higher than 1,000 dynes, so we are pre-treating the patient very shortly with ibuprostanol before the surgery. So this is the patient referred to my hospital from other country with mean pulmonary artery pressure 53, normal wedge, and low cardiac index. Pulmonary vascular resistance was close 10 good units. So the referring physician decided to reduce the weight of these very obese patients, and we can see what's happened during 1 year. During 1 year, probably due to peripheral vascular remodeling, we can see the increase of pulmonary artery pressure, further decrease of cardiac index, and increase of pulmonary vascular resistance, despite the angiography looks still as operable. So we decided to pre-treat the patient with ibuprostanol several days before the surgery. The hemodynamics was significantly improved, and the patient was successfully operated without any perioperative or post-operative complications. There is not any recommendation for the general approach. There is an individual approach from every center. So we are using in this situation this approach several weeks, 2 or 3 weeks pre-treatment with ibuprostanol before the surgery. It is also very important to follow the patients after the surgery, because the patients at high risk are patients with persistent severe hemodynamics after the surgery, the patients with mean pulmonary artery pressure higher than 35, 38 millimeters of mercury, and higher than 5 Wood units pulmonary vascular resistance are at higher risk of death. So those patients should be treated with the multimodal treatment with medical therapy or BPA. So this is the first very important part of those patients when we don't have any risk scoring system, but we are very carefully focusing on patients with very severe hemodynamics, and it is very important to look for the patients during the follow-up, mainly for the patients with residual pulmonary hypertension. Shortly about BPA. So this is similar when we look into the guidelines. There is nothing about any risk stratification in patients who are candidates for BPA with or without medical therapy. Like in surgical treatment, our treatment goal is not decrease the risk of patient. Our treatment goal is to treat to pulmonary vessels with the balloons and relieve symptom treatment, treat all lesions which are treatable, improve quality of life, and of course, improve significantly or even normalize hemodynamics. It is very important, again, to have a multidisciplinary team for the correct decision who from the patients should be treated with surgery, who is candidate for BPA, who is candidate for combination therapy, and you should have significant experience, and the experience are defined in the current guidelines based on the at least 100 procedures per year in one center. Despite this, like in surgical therapy, we have some factor which can affect the long-term outcome, which is the prevalence of the complications, mainly the lung injury. And the lung injury, or the prevalence of the lung injury, is associated with the hemodynamics before the surgery, before the intervention. Patients with severe pulmonary artery pressure, higher PVR, are at higher risk for lung injury than in patients with better hemodynamics. And based on this hypothesis, the randomized clinical trial comparing the pre-treatment and not pre-treatment before the balloon pulmonary angioplasty was created, and those are the results. If you are starting with balloon pulmonary angioplasty and then you are following with the medical therapy, the risk of the lung injury and hemoptysis is significantly higher than in patients with PVR higher than 4, initially pre-treated with the medication, and then as the second step treated with balloon pulmonary angioplasty. And the final effect on hemodynamics is similar in both arms, if the patient was initially treated with the drugs or initially treated with angioplasty and then combined with a medical therapy. So again, despite there is not any risk scoring system, so we are treating the vessels, we are trying to normalize hemodynamics, but what is critical for the stratification and differentiation is a multidisciplinary team and sufficient experience. So one example again from my center, so this is a patient diagnosed in 2013, is a classical operable case. There are proximal lesions on the right side in middle lobe, lower lobe, and again on the left side in upper lobe and lower lobe. And the patient was decided to be operable during the multidisciplinary team discussion more than 10 years ago. So pulmonary endarterectomy was performed in 2014, and we can see that a specimen representing relatively peripheral disease, but there is improvement in hemodynamics, but there is not normalization. So the next step is not to categorize the patient based on the different risk score or strata. The next step is again to discuss the patient based on the hemodynamics, based on the imaging in multidisciplinary team, and the multidisciplinary team decided to treat the patient with a medical therapy and BPA. So we did this, and after 2 sessions and riociguat, the patient was significantly improved, and the patient was in function class 1. So this was the patient decision not to continue with further sessions of balloon pulmonary angioplasty. So we can conclude this part that for surgery and BPA, the critical point is multidisciplinary team, sufficient experience, good imaging, and to improve hemodynamics in patients with severe hemodynamics before the surgery or before angioplasty. And I will move on to medically treated patients in this cohort. So again, there is nothing about some risk stratification into guidelines, but we are more close to the group 1, pulmonary arterial hypertension. This is a nice picture describing the pulmonary vascular disease, which is not the same as in patients with PAH, because there is one significant exception, which is the role of bronchial arteries in this peripheral vascular remodeling. But despite this, we are more close to PAH, and in the position paper of European Respiratory Society, we have the description that we have the drugs with a label for inoperable disease. This is a riociguat and also subcutaneous treprostinil. And also the oral drugs, which are not already approved for this, are acceptable to treat this pulmonary vascular disease. So also the combination is available or is acceptable. So this is the table from the current guidelines. So we have different instruments how to treat pulmonary vascular disease, monotherapy or in combination, but we don't have any guidelines how to manage this. And this could be the room for the potential risk stratification, because this subgroup of patients which are not treated with surgery or angioplasty is very important. It's not so rare in many countries, 15 to 20%, and the long-term outcome of those patients is very poor. So this is one of the first publications showing that the risk scoring systems which have been developed for pulmonary arterial hypertension could demonstrate the different survival in the patients with inoperable or operable thromboembolic pulmonary hypertension. This is the system adopting from the guidelines in 2015. This is the French non-invasive scoring system, showing that the stratification system is able to stratify the patients to low, intermediate, and high risk. What is very important that if the patient is changing regarding the risk status, the long-term outcome is improving. So it is here, those are the patients persistent in intermediate risk, and those are the patients improving from intermediate to low risk strata. So it's important in this very specific cohort of patients that if we are improving the risk status, we are improving the long-term outcome. This is another demonstration that this stratification system already developed for PAH could stratify the patients. This is the Swedish cohort showing that patients to a very important demonstration that the patients which have been improved from intermediate to a low-risk cohort are better than patients which are stable in intermediate cohort. So we have the demonstration that it could be adopted despite it was not developed for this cohort. We should be very careful that it is probably not validation, because the derivation cohort is quite different than CTEP. But the question is, if we have the instrument to stratify the patients, if we have also the instrument to improve the risk of those patients. So the answer is probably that yes, because we have to drug with a license for inoperable or residual pulmonary hypertension, which is the riociguat, based on the CHEST study, and we have also the data from the CTREP study with subcutaneous treprostinil, and this drug based on this study was also licensed in inoperable or residual CTEP. So we can see that in patients coming from the CHEST study, which was the study with riociguat in inoperable and residual CTEP, using different scoring system is able to predict long-term outcome regarding survival and regarding long-term survival without the deterioration. And then we have the analysis of patients treated in the chest study based on the scoring system derived from REVEAL. So this is the cohort which was allocated to active treatment, and this is the cohort which was allocated to the placebo arm. And we can see that over the study, during the 16 weeks in chest study, the patients which have been in active arm, those patients have been significantly improved, or there is a significant part of patients with the improvement over time when compared with the patients which have been in placebo arm, when the improvement is only in a minority of patients. And the patients with the improvement, they have been better regarding survival without deterioration. Regarding the survival, regarding the rate of death, the system is not able to stratify it because the patients included in the study have been highly stabilized. So this is a demonstration that we have the instrument to improve the risk status of patients treated with riociguat, and we have also data that we are able to improve the risk of patients treated with subcutaneous treprostinil. Those are the data from the CTREP study. Not all 105 patients included in the original cohort, but only 81 patients with BOOF parameters at baseline at the end of the study. So you can see that the patients which have been allocated to high dose and low dose arm, which is quasi-placebo, is nicely balanced. And we have used the same parameters like in the study with riociguat. So 3 parameters have been excluded, which are not typical for CTEP, so type of PAH, pericardial effusion, and DLCO. And first of all, you can see that at baseline, the risk status of patients are more severe than risk status of patients included in the chest study. So this is a quite different cohort with very severe pulmonary hypertension. And over time, we have been able to demonstrate that in the group of active treatment, there is a significant improvement in 15% of patients, even by 3 points, in 15% of patients by 2 points, and in 25% of patients by 1 point in the REVEAL risk, when compared with the low-dose arm, when the improvement is not so significant. And when we compare the total sum, you can see that the mean difference is similar, like in patients treated in chest and analyzed by REVEAL risk score. But the difference is that the baseline characteristics of those patients is more severe than the baseline characteristics of patients treated in the chest study. So when we move back again to the table from the guidelines, so we can see that we have a different recommendation regarding drugs. We have the scoring system which is not validated but should probably stratify the patient based on the risk. And of course, we have the instruments when we can decrease the risk and decrease the survival of patients. We have 2 approved drugs, and the guidelines also showing that we can use the drugs without approval in monotherapy or combination. So let me conclude that the risk stratification is one of the main tasks during medical practice in general. Main therapeutic effort in CTEP is to treat pulmonary vessels with surgery or angioplasty, not to reduce the score, the risk of patients. But the role-oriented approach in the CTEP is limited. In surgically and interventionally treated patients, we are focusing on severe hemodynamics and very careful outcome after the surgery or intervention. But it could be higher role of the risk stratification and goal-oriented approach in medically treated patients. Observation in patients with inoperable and persistent recurrent CTEP demonstrated the potential utility of the scoring systems developed for PAH. Prognostic factors specific to CTEP are not included in those risk stratification model, which is the probably main limit of them. And we have the drugs which can modify the risk of patients, and we are able to improve the risk status of those patients and improve long-term outcome. Thank you.
Thank you, Dr. Jensen. Please join us, please. Very interesting illustration. And now I have the great pleasure to introduce Professor Eileen Lang. Professor Eileen Lang is a clinical cardiologist and professor of vascular biology, Medical University of Vienna. Professor Lang is going to, in an evidence-based approach, she's going to talk about multimodalities of CTEPH management.
Thank you. Yeah. So I thank the other speakers for paving a great path for me. This was excellent, and I'd like to expand some more on treatment strategies for chronic thromboembolic pulmonary hypertension. Here's my disclosures, and I've found this over the years to be a very interesting and exciting subject, both in the basic science area. It was very nicely outlined by the first speaker, as well as in the clinical decision making. So I've used this slide, or I would like to use the slide, showing you the timeline of CTEPH science and leading us to where we are today. And this is the International CTEPH Association registries that are worldwide and recently reaching out to even further areas in the world. We learned from the first registry, and you see here, this is like almost 20 years ago now. What are those patients like? How can we describe best the CTEPH group compared with PAH? In the second registry, we learned the effects of riociguat in addition to surgery. And we also had our first experience of European balloon pulmonary angioplasty. Finally, there was an intermission where balloon pulmonary angioplasty itself became the subject of a registry, and this is the ICABP registry that has been in some aspects presented at the recent ICC meeting in San Diego. And finally, the third registry, which is where I'm standing, which is the multimodality aspect of CTEPH treatments. And I think today there is good evidence supporting multimodality. So what are our targets? I'm using a surgical specimen that was retrieved by Michael Madani as my model, and you can see, although this is all surgical, look at this as a cast of the pulmonary arterial tree. Proximal is really the target for pulmonary endarterectomy still today. Distal is still the target for balloon pulmonary angioplasty. So this is mechanical treatment for a mechanically driven disease. This is in the guidelines, and it's very good to see this over and over. The central role of the multidisciplinary team is undoubted, and pulmonary endarterectomy as the first choice is depicted here with medical and BPA to follow this decision. And this is an example of an MDT. It's very nicely put in the guidelines as a green, yes, please. It is recommended that all patients with CTEPH are reviewed by a CTEPH team for the assessment of multimodality management. You can see the components, the surgeon, always surgeon. This is the important species in this multidisciplinary team. PH physician, cardiologist, radiologist, anesthesiologist, and of course the nurse specialist, and maybe the patient representative comes in here at some point because we involve patients in decision making. So how do they decide today? And it was very nicely outlined by Pavel that what the MDT is really doing is think about risk, base their decision on their own personal assessment of risk. And there's no risk score as yet, but I think it will come soon. And we've seen this European three-strata model to drive decisions. Pavel has shown us that several investigators have shown that it is useful and can be applied to CTPH, but not completely. And let me take this a little further. So looking at hemodynamics, we can, in the cath lab, obtain more information to risk stratify. And this is from a manuscript that I published with Christian Gerges, where we used pulmonary flow analysis to describe the slope between the pulmonary arterial pressure curve and wedge. If that is steep, that correlated with less vascular disease. If that is flat, this correlated with much more vascular disease. So this would be a means to understand the component of microvascular disease, which is, as we all know, a contributor to PVR, a contributor to severity, a contributor to outcome, a contributor to post-PH. Furthermore, vasodilator testing done in the cath lab, and this is unpublished data from one of my PhD students, was looked at in 325 patients, and those who dropped their mean pressure 10% had a much better outcome when they had surgery. And in the group that was not operated had a better response to riociguat and other vasodilators. So I think vasodilator testing can help us classify, is this a more or less hemodynamic, risky patient? Furthermore, if we do proper phenotyping with measuring the left heart pressures, you can use wedge, which is not always useful. If you do LVEDP in this population, you may assess increased left ventricular filling pressures, and that classifies a group with higher risk, with elevated left ventricular filling pressures, from a group with normal or low left ventricular filling pressures. So this is maybe a component in decision making and may enter a CTPH risk score of the future. Next step, lesion assessment. We do a PAG as shown here, very typical. You have seen the example of Dr. Jansa. Segmental defects, usually more on the right side than on the left side. This is also an interesting feature. And the understanding of lesions has been driven by the Japanese groups who have refined balloon pulmonary angioplasty. And they have pointed out there are lesions that are low risk. The rings can be actually dilated by any one of you, and the complication rate is low. If you address total occlusions or tortuous, you may run into more problems, and particularly tortuous is associated with a higher risk. So lesions must go into a CTEPH risk score and will also interest surgeons, because tortuous lesions will show they are also not great for surgery. Next step, comorbidities. So which type of comorbidities is my patient carrying along? And this is a paper that's actually a long time ago from my group, where we showed if you have associated medical conditions such as ventricular atrial shunts, splenectomy, another condition like Crohn's disease, any condition that is heavily inflammatory, you have a much worse prognosis than if you have a protein C deficiency or any other thrombophilic abnormality. Also an important factor of risk stratification and the decision. So let me go back. Pulmonary endarterectomy, balloon pulmonary angioplasty, medical. So how do we now decide initial treatments? What about PEA first? Everybody would say, of course PEA first. This is a great technique. It opens up the arteries. It is very efficient. It clears out even small arteries in surgeons' hands. And survival was always excellent compared with patients not undergoing pulmonary endarterectomy. However, about half of patients are not operable still today. I would think maybe even more outside of our center structures. And there is post-PAPH, however you want to define that. You know, it's very poorly understood yet, and it's a very important future target of CTPH research. So what about PEA against BPA? There is one study that is ongoing. It's called the GO-CTEF study. No data yet. We will report on this. I talked to you about this last year, I think. So what about medical? What about medical to everybody? I remember this was promoted after the CHEST trial. And this is a summary of all the randomized controlled trials that were involving a significant amount of patients. And you can see on the right side, the change in PVR in percent and mean pressure in percent. And it is still modest in isolation, medical therapy in isolation. But it's effective. What about BPA first? So BPA has been, you all know, it has been practiced in Europe first in Boston. It was 2001, then was dropped because of higher complication rates, and then brought back by Japanese interventionists. And you see at the top a typical lesion here. This is a complex web lesion, but it's very nicely dilated, and vessel grows as we wait and see, and the pressure goes down. So BPA is not a one-stop shop. It takes many, many procedures to get there, usually 4. And I'm sorry, I'm jumping. And it has to be planned accordingly. So patients have to know what they are looking at. Efficacy is excellent. This is a recent summary in the European consensus statement. Mean pressure decreases by 40.2 and PVR by 50.9%. So excellent data for BPA in isolation. There is complications. The slide was shown in San Diego recently. So hemoptysis is being the most common. We classify them as thoracic and non-thoracic. Usually the 9% of sessions, 30% of patients is what we see. And interestingly, females have more complications in the BPA cath lab. So do we do now medical or do we do BPA? This question has been answered by 2 studies, Mr. BPA, the Japanese study that you all know well. They compared a BPA group with a riociguat group and found that BPA was more efficacious. A very similar setup in France, starting 2013, was a pragmatic trial looking at non-operable cases who were eligible for BPA, randomized to riociguat versus BPA and standard treatment, assessed at 6 months. Primary endpoint was PVR, and did a second evaluation at 12 months. And I think this study was very important because it gave a number of answers. First, BPA was more efficacious, but there were, of course, complications. Second, the question, medical therapy and BPA, was also addressed by the study because it swapped after 6 months the primary BPA group to Rio if they needed it, and the primary Rio group to BPA if they needed it. So they obtained a combination of the 2 treatments, illustrating very dramatic efficacy of the combination. In addition to this, they saw much less complications in the patients who had been pre-treated with riociguat. So very interesting data that still need to be confirmed in larger series if this is ever possible. Very similarly, Christoph Wiedenroth in Bad Nauheim published the effect of the combination of BPA with medical in a sequential fashion, and he showed that the mean pressure was much more effectively lowered in the presence of riociguat in addition to BPA. In the BPA registry, as was shown in San Diego, medical is the companion of BPA. 70% of patients were on meds, and 60% were on meds after their last BPA. 70% before BPA, still 60% after. So this seems to be a good combination and also practiced. So what about before mechanical intervention? You do know there was some evidence that There is no sign of improved survival if patients are medically pre-treated before pulmonary endarterectomy. This is from the first European registry. You see the red is the ones who received bridging, and the blue is the one not receiving bridging, so there's no difference. The Jensen study in San Diego illustrated that medical treatment was associated with delayed referral in San Diego, and this is the data for this study. You can see no benefit there. And finally, we did a study that me standing for ICA, riociguat treatment as a bridge to pulmonary endarterectomy. This was the bridging study, was very nicely designed for patients with high risk who were pre-treated, and then the primary endpoint assessed at the time of surgery, but the study wasn't complete. It was prematurely stopped for many reasons. There's one more study interested in the pre-treatment before mechanical, and this is the IMPACT CTEPH trial in France, where RIO is combined with placebo or macitentan prior to BPA. And this will be a very interesting study as well. So what do we do currently? I'm almost finished. We currently work on as a multidisciplinary team with the 3 treatment options, and we have been very successful. You see here the green line. I will go back to illustrate that well. Operated was always excellent, non-operated, of course, worse. This was in 2012, and today we've got the not operated up here with BPA and medical. So you see, this is a tremendous success for the multidisciplinary team and the multimodality treatment. We cannot deny that. We have to still build a CTEPH risk score to put decisions in the hands of the multidisciplinary team and maybe in the hands of artificial intelligence at some point. And there is variations to the theme. This is recent. You can also do multimodality treatment sequentially. Medical treatment for these patients with mixed anatomic lesions. This is from the French group, where medical is initiated, BPA is done, in this case on the left side, and pulmonary endarterectomy is done on the right side. And this is illustrated here in terms of the change from baseline after pH-targeted medical is the orange, after BPA is gray, and you see the power of mechanical treatment after PEA is in the yellow. So this may serve as an example of complex treatment management in an expert center. The team registry is now recruiting. If you are interested and empowered to be part of this, we will be studying multimodality treatment in a worldwide setting. In summary, in 2024, modern management of CTEPH is the undoubtedly multimodality approach. The multidisciplinary team decides what is the initial strategy. Is it PEA, BPA, or medical? Do we start all 3? We just discussed this. And I want to point out the initial treatment, because it doesn't mean if you've had PEA, you cannot have BPA, as Pavel showed very nicely. So the drivers of treatment decisions are risk assessment tools. And these are currently hemodynamics, of course, patient age expectations, I've not forgotten, comorbidities, I want to emphasize this, the disease type, and the relationship between hemodynamics and lesions, and of course, associated medical conditions. Don't forget them, they're not so rare. And finally, the level of our expertise. Thank you.
Thank you so much, Professor Lang. It was a great talk and review about the multimodalities of how to approach CTEPH patients and how to treat those patients. And it's my pleasure now to introduce the next speaker, Dr. Ali Saud. He's an interventional cardiologist and adult congenital heart disease specialist at McGill University in Montreal, Canada. And he's going to talk to us about balloon pulmonary angioplasty in CTEPH patients. Go ahead.
Hello. Assalamu alaikum. Do you hear me? Okay. Excuse me. Thank you very much for inviting me, Dr. Abdullah Dalan. Thank you, Mr. Hassan Al-Araini, for this amazing organization. And I'm truly honored to be part of such exceptional faculty, really leading the way and moving the field forward. The CTEF speakers are really, tough acts to follow in other topics, not to mention BPA. So the previous title was Analysis from a Canadian Center. I mean, there's no data that I would be able to present that would have any scientific value compared to what was presented before. But I decided to share my personal journey and experience with BPA. And that might have a little bit of a value for whoever is interested or considering starting a program, and mention the difficulties or the real life issues that you might face when you want to do this. So I have no financial disclosures, but I'd like to say that I'm not a PH specialist. I'm just a hobbyist. I'm not a pulmonologist. I really enjoy working with them. I'm not saying this because the majority are pulmonologists, but if they would just stop saying give more Lasix. And I am biased towards BPA. So what is rationing? Rationing is you probably do this in your daily life and not really know it, but it's an economic term in terms of ensuring healthcare delivery to everyone in a rational, equitable, and a cost-effective manner. Sometimes that leads to potentially withholding treatments or programs for people that might benefit, because adding a new therapy costs money, adding more time competes with other programs. So it's a priority setting approach, and hopefully with that you get the maximum benefit with the most effectiveness. We've seen the data. We finally had randomized controlled trials end of 2022, published along with the magnificent 2022 ESC guideline paper, showing an impressive improvement in hemodynamics with BPA, albeit with side effects or complications, but that are really acceptable for the results. And of course, based on that, you get the Class 1 designation, which was a huge win for BPA. But great, so now you can send a third of your patients to BPA, non-operable patients, or maybe start with BPA. But where do you go? So when we decided to start the BPA program, we were faced with multiple challenges. First of all, getting the education. It's rare, you don't have a lot of places in the world that do it, or programs. So how can you train one or even more people to do it? Two, the evidence at that time at least was not robust, so trying to convince people that this is something that is very important is difficult. Three, procedure duration. It's long, it competes with other procedures, and if you start, you must do it right and must be safe. If you run into complications, it might really slow down the progress. As an interventional cardiologist, I know the coronaries very well. There are two osteas, multiple catheters to use. But when you compare that to what a pulmonary angiogram looks like, it is a different world. And the anatomy is really, really difficult to get. Not to mention the variations that come with it and the directions of each segment. You can go anterior, posterior, superior, inferior, medial, lateral. And that really adds to the challenge of understanding how to do it. So it is, in terms of volume, it is a relatively rare disease. It's a complex anatomy. It's a large vascular bed that you can't complete in one session. It would require multiple times. It is time consuming. It's a contrast load. It's radiation exposure. And it's not without complications. And there's a learning curve to it. So my journey, or our journey with the BPA, starts in September 2017, when Roxanne was one of our patients, a 17-year-old female with severe CTEF. She undergoes an endarterectomy that unfortunately is not successful, ends up spending 3 weeks in the ICU, barely makes it alive, and then is discharged from the hospital. And at that time, some of you may know him, the head of our PH program, Dr. David Langleben, tells me, Ali, you have to start doing BPA. So I was very excited, and I replied, what is BPA? At that time, it was not as common, but he said it's something that's being done elsewhere, and you can try to go to either Japan to train in it, or I said, say no more, I'm going to Japan. Didn't care about BPA at that time, but I went to this lovely city called Okayama in the west of Japan, where I met Dr. Hiromi Matsubara, whose picture was presented earlier, and his name became synonymous with refined balloon pulmonary angioplasty. During those 2 weeks, there were like 3 BPAs a day, but so much to learn: angles, equipment, techniques, complications, and it was a culinary experience as well. So we went back in May 1st, 2018, and did our first balloon pulmonary angioplasty in May 31st, 2018, in an 84-year-old lady. So some technical aspects, I don't want to spend a lot of time, but we have a biplane lab. Some people do it on a single plane. I think there is a big advantage from doing a biplane. The equipment is usually the same as in terms of access when you do your right heart cath, whether it's intra-jugular or a femoral vein. We recently did a subclavian and an interrupted IVC with azygous continuation, and it worked very nicely, probably better than an IJ in my experience. And then the rest is like corner equipment, wires, and balloon, which as interventional cardiologists we do all the time. This is an example of what happens. So we go very selectively into the segments and sometimes deeper in the subsegments. On big, deep breath hold, try to straightens the vessels, make it easier. We advance our wires and hope to stay in the vessel. Once we are able to cross, we use the balloon for support, and then here patients can release and breathe out. Look at on the biplane, the difference in terms of like the straightening of the wire when patients take a big breath in and when they are at expiration. And it's very variable when they're functional class 4, pleural effusions, small lung fields. It becomes very difficult. When they're really cooperative, it makes a big difference in terms of the ease of procedure. We balloon the lesion. Usually less is more, smaller balloons. We don't have to oversize. We also take into consideration the pressures, and then there's a significant improvement in flow, usually. So deep inspiration, very important. On average, we try as much as possible to do one side. Sometimes you can do only like half a lung, sometimes you do the full lung, depending on patient's cooperation and ease of crossability, and with time also that might happen. We monitor patients overnight and they get discharged early in the morning. And we repeat that it is repeated on average about 4 times per patient. So each patient would require on average 4 sessions. Could be anywhere from 2, 8, sometimes 10 if you aim for perfection. And this is when we came back, this was our list. We had around 60 patients on our medical therapy list who were being considered for BPA, and this month that increased to up to 111. So we were ready to start, and we went on. This is just what we did so far is like 107 patients had BPA. I think we have 4 that didn't. And about 2/3 are females, 1/3 are males, and the rest is, you can see, about 9 patients had an endarterectomy in the past. But look at, and I come back to rationing. We have 60 patients, average 204 BPAs, but by February 2024, we only did 209 BPAs. And if you look at the distribution of that, the first, the 1 or 2 BPA in about over 75% of patients, and only like 15 patients had 3 BPAs, 8 patients had 4, and only 1 patient had a 5th BPA. And these are the wait times, or the times between the first BPA and the second BPA. If you look at it, I mean, it's nice to space it for like 6 weeks, 8 weeks, but in reality, we were months between the first and second, and over like years between second and third, and even longer between third and fourth, just because we were prioritizing patients based on how sick they are, and we had limited time in the lab because we were competing with many things. If you look at the annual volumes too, when we started, the first, I would say, half year in 2018, we did 11 cases. 2019, it was 25. 2020, 32. COVID hit. We had actually more lab time, but it was more difficult to bring patients into the procedure. 21, 22, about 40. And finally in 23, despite me not being around a lot, we finally did more than, on average, 1 a week. On the first 4 weeks of 2024, we did about 7 cases. These are our results. I mean, you have to keep in mind that BPA hemodynamic results really require about 6 to 8 weeks to get the optimal result. If you have data, I mean, we do a right heart cath pre every BPA, post every BPA, but the data we have mostly is after the second BPA, so it does not reflect the effect of a truly second BPA, so you can say it's about 1.5. But there was still a pleasantly surprising improvement in systolic pulmonary pressure, mean pulmonary pressure, and an improvement in cardiac index, as well as a reduction in PVR. Our WHO functional class also, we had a few patients in functional class 4, majority in 3 and 2, and then that actually improved. We had a few that now are class 1 and more limited follow-up, I must admit, but like more class 2 and less class 3. These are just examples of what we do. These are, again, subtotal lesions. We cross, balloon, and when we see these big vessels open up, we really know that these patients are going to do well. Same thing, open up, big vessels appear, very, very rewarding when that happens. Not all are like that, but those are, you know, whenever it happens, we're very pleased. These are examples of also very early experience. I think it was, December 2018. 2 BPAs come back later on, after 2 BPAs, quite significant improvement in the right ventricular size and function, right atrial size, and maybe a bit busy slide, but if you look at the mean pulmonary pressure of 59, it went to 27 and 26. Same thing with PVR. Another patient was in like really cardiogenic shock, big pleural effusion, huge RV, RA, very impressive improvement. Also the duration. This is a lady that was followed in our CTF clinic for about 9 years, came in for 2 BPAs, and her mean pulmonary pressure did go from 48 to 25 after 2 BPAs. But despite all these great results, sometimes things are not, as good as we want. This is probably I would say the only procedural mortality that we encountered. As Dr. Lang mentioned, females tend to get a little bit more complications, but this was very unexpected as the wire just went through, it's like going through tissue, Kleenex. And we had to, I believe, injected some gelatin there. And even though she didn't die during the procedure and we didn't need to intubate her, she required a little bit of optiflow, she elected to be palliative and didn't want to. So complications, I think we shared the same picture. Hemoptysis, most common. And no matter how hard I think we try, it's in the range of about like 10%. Fortunately, other major complications are less. We can have like desaturation related to lung injury. PA dissection is usually not a big issue. And the PA rupture, if we size properly, we shouldn't have that. And hypotension, shock, and side bleeding, of course, are problems that may happen early on. Later on, less common also. Most of the complications happen immediately. Next day, oxygen requirement increase rarely happens, but usually is either reperfusion, pulmonary edema, or lung injury. Desaturation, tachycardia, rarely shock. This is a nice demonstration how the initial period of BPA had way more complications compared to the later period. There's also a local experience and there's an international experience. We tend to learn when to push the envelope and when not. If the hemodynamics are worse, yes, probably there is more risk of complications. If it's low and there is underlying medical therapy and you're able to reduce the pressures, probably the complications are going to be less. As a center, you become a little bit more experienced and you know exactly, or you get to improve in terms of your efficiency and what to tackle and what not to tackle. Just an example, you might see a little bit of staining here. This is a very mild wire-induced perforation that is usually not a problem. And with only wedging the catheter, you might allow it to stop and you can move on. But unfortunately, it's not a picture I'm proud of, but I just wanted to show you the close relationship. Look at the contrast being injected as the catheter is wedged, and it immediately goes into the bronchial circulation. See all these bubbles, it's mixing with air, and as soon as you have any minor or micro perforation, it immediately goes into the bronchi. And this is just the contrast being ejected, and of course, the patient gets, starts coughing. And I don't know if we here had to deal with massive hemoptysis, maybe as pulmonologists, you do from time to time. I always ask cardiologists, and they rarely do, but it is a very stressful situation for everybody, for the patient, and it's and doesn't get better with time. So you see the bubbles there. So we had to inject gelatin here, or gel foams like gelatin sponges, and occluded the artery. But a week later, she came in, and she was actually a very young lady with prosthetic tricuspid valve endocarditis, and it was more septic emboli. Very tortuous vessels, as Dr. Lang mentioned, they're more difficult. But then the gelatin gets reabsorbed very quickly, and you can actually go ahead and try to either dilate or address the lesions. PA dissection, usually not a big deal because it might be, even though it looks very ugly here, it probably is separating a thrombus or you're within clot. And not only that, but when you have a total occlusion like this, you really, this is clearly a surgical case, but it was not an operable patient. It shows you where to go. In terms of like the blunting here, you don't really know where to go. Now at least you see the apex of these triangles, so you can be more aggressive and find your way in. And that's what we actually ended up doing, small balloon, and you open which is supposed to be a big segment. It does grow and become bigger, and you can go with bigger balloons after. But as you can see, we can't really push too much there. But our experience, even though we didn't have like a catastrophic BPA complication, something that you might run into when you're doing your right heart caths is a swan-induced rupture. And that is a catastrophic, definitely worse than a BPA complication. And with a little bit of our experience in the pulmonary circulation, I was called to run to the cath lab because they ruptured. The first kind of reaction when a coughing happens or hemoptysis happens, we tend to pull back the swan. But the thing that should be done is inflate and push, and it tends to kind of go to where it was and just seal the hole until you can do something about it. And that's what saved this lady, I have to say. And then you can see that there was like a contrast extravasation from this potentially vessel. But when you look at the biplane, and that's why I really strongly suggest using biplane when you want to do this procedure, is that you think that it might have been this vessel that was ruptured by the swan, and actually it was this small one here that was overlapped in the AP view, and this is the one that we went in and put a covered stent, and then at the end, it was really not a problem. It was a right heart cath for a PH workup patient, so it was not CTEP or anything. Another less fortunate patient, the problem with the hemoptysis is you can't intubate them. You can't do anything. They have to arrest or you have to put them on ECMO. So on chest compression, I don't know how that happened, but the catheters tend to also fall in the same place just because of the bias or the trajectory of the vessels. So there was a big gushing hole that we had to go and balloon. Now the anesthesiologist was able to intubate the patient. We stabilized her, and then we had to put a large vascular plug. Mind you, sacrificed the lower lobe, but she survived, and that was good news at the end. This is our rate of complications, and then out of the 209 sessions, 107 patients, we, no matter how well I think I've become in terms of being efficient, it's 10%. Like every 10th case, I would get a hemoptysis. Most of the time it's controlled. Reperfusion, lung injury, I would say, is about 6.5%. Reperfusion edema, I had 3 patients. One DVT, one arterial hematoma. It was a right and left that I did an ad hoc BPA, which I stopped doing after. And this is the one that died, unfortunately. It was the only one that we used a nasal high flow cannula, but we did not require to intubate any patient. We didn't put any patient on ECMO, and we had 1 procedure-related death and 2 deaths within 30 days, which is somewhat in line with the published data. So, but there was a lot of limitation here that despite having 100 patients, which is a decent volume for BPA, we really have relatively limited number of BPAs. We had limited follow-up, and the hemodynamics that you saw are, 75% are really just immediately after the second BPA. Plus, because total occlusion are a little bit more complex, we don't really have a lot of, we don't push a lot because we have so much more to address before. So this is our approach. Our wait list is dynamic. Might have someone scheduled, we get a sicker patient, and they will take place. It's based on risk stratification. Worse hemodynamics, patients are more symptomatic, they require oxygen, they get hospitalized, immediately, automatically get prioritized. If there are severe hemodynamics, there's some evidence that says that there are limits, so you would start riociguat and maybe double therapy to try to reduce the pulmonary pressure, makes the procedure easier. We don't really have a limit to or a particular number, but you need to limit the balloon size at the beginning. Not necessarily the number of segments that we're going to do, but we don't push very hard. And then if the hemodynamics are mild to moderate, then we're comfortable pushing really hard and even addressing chronic total occlusions. And operability, again, guidelines, as was mentioned, tell you that it's only for inoperable patients. I think any BPA center now has changed, and any MDT that have access to BPA would tell you that it really is on a case-by-case basis. You know your team, you know your surgeon, you know what the outcomes are, and that is somewhat dynamic. Also weighed with not only the procedural risks, but it also is the patient-related risk factors as well. So as Dr. Matsubara always said, like, for us, this is what we do. But I'm glad to see that it is changing, and it's all based on MDT. So what we also do is that for level 1 main, there is no reason for you to go for BPA. This is just like an easy surgery. The surgeon will do an amazing job, and patient's going to do very well. Number 2, low bar here, we might actually consider BPA if we're concerned about patients, if the hemodynamics are severe, or we might just address the non-CTO lesions. But if they're otherwise straightforward surgical candidates, they would go for that. But whenever we reach level 3 or more, I mean, now it's almost a non-discussion. Oh, we go just for BPA. So the treatment goals are symptom relief, addressed or exercise. We target a saturation at on room air that's above 95%. And we do target a mean pulmonary pressure of 25 or at least 30, which is our kind of like, as published, to be the prognosis threshold. Whatever is less than 30, based on endarterectomy data, seem to have a normal survival, or like an equivalent survival to normal patients. And the targets change based on the individual lesion, like the technical complexity, the age, and comorbidities. We're more aggressive. The last BPA I did before coming here is for a 91-year-old, which I never thought that I would do, but we did 2 sessions. She left the hospital off oxygen, and the key is, if they tell you they live alone, you do it. So what I learned, that establishing a BPA program is a huge undertaking. You have to understand that it's not just, oh, I have a couple of patients and I'm going to do BPA. And if you want to start it, you have to start it right. You need volume. You need to be a center, which is the referral center, and you have a few patients that are waiting, and you go one by one, because doing one case every month really is very difficult. I can tell you the first BPA are definitely much more, very different than the last 50 BPAs that I did. There's a learning curve, particularly, even though as interventional cardiologists, we use that equipment on a daily basis, the anatomy is very, very different. So you need to do a large volume to become comfortable or be trained in a very large volume center. And ideally, you would want to have 2 operators. It's a bit difficult to be the only one doing it, and having someone else for discussions and all that is definitely something that is like highly recommended, but it's not easy to find a second person. It's also time. You compete with coronary cases, you compete with structural cases, you compete with all sorts of cardiology, whether you're interventional radiology or cardiology, you compete with a lot of procedures. So ideally, if you can have a dedicated pulmonary hypertension lab for the for this and the right heart catheter would be good. This is a personal thing, and I'm nearing the end here. It's just that radiologists may have interest, and cardiologists as well, but I think each have a little bit of advantages. So cardiologists, they use the coronary equipment, they're good with hemodynamics, they are good with chronic total occlusions and dealing with hemodynamic instability and the need for ECMO. Well, radiologists definitely are better than us in anatomy, in multimodality imaging, embolization, if need be, and or experience in different vascular beds. This is a neat study, just very briefly. It's just we're measuring the functional capillary surface area post-BPA. This is just the first one that we did. And immediately post-BPA, we had a 38% increase in the functional capillary surface area immediately. Even though the improvement is 6 to 8 weeks later, it was just a pleasant thing to see, but we did about 8 or 9, and we don't have the analysis. We're doing the same thing for Fontan patients, but we're focusing on that. And finally, we also ventured on other things. We spoke about the journey from PE to SAPH, and this is a patient with massive bilateral PEs in the context of a stroke, not a candidate for anticoagulation. So we started our PERT program, where we went in with a device to just extract that PE, and with an impressive recanalization, impressive hemodynamic effect. So perhaps, and this is something that's really coming in the near future, and you will hear about it more and more, but maybe if we address those cases as well early on, we might avoid having that cast that will end up causing SAPH. So to conclude, we are really coming back to the end of the journey where Roxanne was the catalyst to start our BPA program. By pure coincidence, Dr. Matsubara was visiting Montreal and for a meeting, and he joined me in her BPA just because she was scheduled the next day. This was her hemodynamics at baseline, post-PEA, and this was it after 2, and then she actually wanted to get pregnant. We did 2 more, and mean pulmonary pressure was 22 and a PVR of 1.7. She lives a normal, completely normal life. And I would leave you with the last, but in my opinion, the most important lesson that I've learned is that teamwork. Medicine is a team sport. And really, we're at our best when people know what they're doing, and when patient care is at its best when everyone is like doing their role. I think SAPH in per se straddles many specialties, and as we can see, and each of us have their, we're good at things and we're less good at others, but when we get together, we really have the best outcome. I'm very lucky to be doing such a very gratifying procedure, but I really would go nowhere without the nurses, techs, pulmonologists, cardiologists, cardiac surgeons, intensivists, and that have been are very invested in these programs, and it grew exponentially, and we're having great results, so we're very, very proud and very pleased. And I'd like to thank you for that, and I'll be happy to answer any questions.
Thank you so much, Dr. Saud. I really enjoyed your talk. It's really fascinating to see how the BPA evolved within years. The first data that came out had a very high complication rate, and it almost killed the BPA, and then Professor Matsubara came up with the data that brought it back to life, and now we're seeing the BPAs improved so much, and it's reaching the class 1 indication in the guidelines in certain cases, so it's really amazing. So we're open now for questions.
Well, what's an amazing session, from pathogenesis, risk stratification, multimodality treatment, and challenges to start a program. Such a great session. Thank you so much for all the speakers. My question to Irene. I was impressed with your last graph. I mean, the green line where the BPA and medical treatment was actually having better outcome than operated patients. I don't know about the heterogeneity of this group. Were all declared inoperable, or mostly because of comorbidity or technical issues, or the level and the anatomical distribution of the burden of the disease. But despite this, and with accumulating evidence, and with very significant improvement in hemodynamics with this procedure, plus minus medical treatment, what do you think in the near future, and maybe with refining the procedure even more, in the near future, will probably this be #1 choice, except for those proximal large defects?
That's a great question. I still think, and I follow Hiromi Matsubara in that, because he has probably still seen more than we have seen in BPA terms, but not European maybe. European are different, and also your population may be different than Japanese. We still believe that surgery may lead to lower pressures. And the experience that I have on surgical patients post-PA undergoing BPA, those are the ones where we reach a mean pressure of 15, young people. So I think there is still areas of advantage of pulmonary endarterectomy that we need to explore. But I do believe what you said, that BPA will further spread out, because there is really not so many surgeons as there are excellent interventionists, and reaching very good results. The question will be, maybe PEA will still be better with an excellent surgeon, but we don't know that. So I do believe that BPA will take over, because there's so many more knowledgeable interventionists than there is excellent surgeons who reach out to the distality.
Excellent presentation. Question for Irene. Back to the risk stratification. You mentioned about vasoreactivity as a marker of disease outcome. So current guidelines suggest that we should limit that undifferentiated pH in the process of evaluation. We normally think, if I have high suspicion for CTEPH, probably I will avoid that. But do you think it's going to become more of standard of care? This is the first question. The second question is, patient with vasoreactivity, how does that kind of lead to management down the road? Are we thinking of calcium channel blocker in that subpopulation? How do you differentiate between, with proximal disease or more some distal disease?
Excellent questions. So answer to question number one is that this paper is still under revision. We have published a previous paper where we have already pointed out that the acute response to vasodilators is associated with improved outcomes in a surgical population. The added information of the second paper, which I showed you, is that we tested the response against classic response and against different definitions of responsiveness, but we add to this that they do better on medical treatments. I do not think I can say at this moment, none of them was, very few of them were classical responders. So the justification for calcium antagonists in my mind is to be a classical responder, but in CTEPH not tested, we don't know. Please stay tuned how this comes along. I do think that vasodilator testing in CTPH has to be done unless they have very elevated wedge pressures. All those with elevated wedge were not in the group, which is important. In the low wedge, no left heart filling pressure elevation group, I think vasodilator testing provides prognostic information. Guidelines have not adopted that, but maybe others will find the same. So I'm hopeful. Calcium antagonists, I don't believe, but medical treatments, that may be an interesting question. How do we take this into our consideration? Thank you for asking.
Dr. Mehta, I have a question for you. In the journey from the PE to CTEPH, and there's a lot of research about the quality of treatment for PE. It didn't prove that it has an effect on the development of, even with thrombolytic therapy, it didn't affect the prognosis. So what about, are you aware of any trials of anti-inflammatories? Because in the pathogenesis, we have inflammation and the angiogenesis, defectiveness. So any trials for anti-inflammatory in the high-risk people? As a pulmonologist now, we have a role for anti-inflammatory, for example, in pneumonia. We have now in the updated guidelines, we give steroids for severe pneumonia. So any trials in this respect?
Well, nothing specific trial-wise. I'm thinking about my concerns. The inflammatory process is, of course, very essential to helping the early resolution. And it's not largely inflammation. I think it's a later phenomenon. It's the remodeling and the growth factors we talked about. And that there hasn't been anything. And I look forward to our basic scientists helping us understand how to target that. And then one quick addition. There is evidence in systematic reviews that thrombolytic use does decrease the risk later of CTEPH. It's not strong, but there is some evidence. And so clearly the initial clot burden is important to the later changes, probably because it changes the hemodynamics in the situation.
Well, interesting. Dr. Lang, I'm actually interested with the upstream resistance measurements. Do you think it's a kind of much better of the BVR? And also I am concerned with how you measure it, because it seems the curve is very, very tiny. And is there any bias for these measurements during the analysis?
You know, the original description is from Lou Rubin and Nick Kim. This was Nick Kim's first major circulation manuscript. And what they did is they used a software from Pierre Fessler developed with Robert Naé, which is a little box that you attach to your measurements, and you can also export curves to this program. It is a very clear mathematical calculation of the slope of the curve. It's very simple. The only challenge is that some people feel that wedging may be dangerous, but it's not. If you learn how to do this,
would be fun.
You can do it in every patient. And you have, if the upstream is greater 60, we know it's a problem.
Again, what is the impression of the surgeons in cases of pulmonary endarterectomy after BPA? What is their impression?
Well, this is very subjective, and surgeons feel threatened by BPA, some of them. The very smart ones know. They go and learn themselves to do this. Christoph Wiedenroth is a hybrid surgeon, BPA interventionist. They usually report that it is much more difficult. I don't know.
I would depict it would be easier.
Yeah, but well, what is done is that we push the material to the side. And so the things to grasp may be more difficult, but I don't think that a talented surgeon has any problems at all.
That's interesting.
The truth, I think.
Any more questions? Okay.
Yes, thank you very much. I have two questions. One for the medical group, which is basically, do you think for patients undergoing successful surgery with resolution or normalization of their hemodynamics, including PVR, do you consider them cured? And if so, what is the risk of, do they have high risk of recurrence of severe form of a disease?
Maybe you answer. You should.
So do you think for patients who are undergoing successful surgery with excellent results and normalization of PVR, are they considered cured, or do they still have high risk of recurrence with severe form of disease to coming back, and especially when you do patients in their 20s and we're expecting them to live to their 50s or 60s, do they come back with severe disease, or that's it, they're cured?
So if the patient is completely treated with the surgery, with the normal hemodynamics after the surgery, so the risk of the recurrent disease is very low if the patient is correctly anticoagulated, including the situation when the patient is undergoing non-cardiac surgery, for example. There is a specific situation in the case of complete occlusion of the pulmonary artery of the one lung and severe collaterals. So in this case, when the pulmonary pressure are normalized, there is a competition with the bronchial arteries, and it could be the risk of the recidiva of the disease. So this is the reason, based on the individual discussion, for the embolization of the bronchial arteries in those completely occluded one lung pulmonary artery.
I think it's a great question, because what is normalization of CTEPH after successful mechanical treatment. That refers to your question, right? Because in big series, the mean pressure after surgery is 20, 27, 25. Is this normal? We say now normal is 20 or less. So I think it's a very good question, and I think we have to study. Okay. What is post-PA-PH? What is post-BPA-PH? It's not so clear.
Mm-hmm. If I could add something, a lot of our assessments at rest. Yeah. I could have a normal PVR, normal pulmonary pressures at rest. If I walk across the hall, cardiac output goes up, my pressures are going to go up. I think many of our patients aren't actually normal. They're very good, functional, active, but I think there's still residual pulmonary vascular damage, both large vessel and microvascular.
So from an intervention standpoint, actually, if I do pulmonary artery stenosis, and from simple congenital perspective, they are the hardest to deal with because the risk of recurrence and stenosis, and you have to do, etc. So what about your procedure? So the simple PEA, so do they face the same problem? It's just ballooning and that's it, no recurrence, etc.
So it's quite impressive, and I think whoever does BPA and more with, now we have longer and longer data, and most of it comes from Japan, of course. The rate of recurrence is very, very low, and is, I think, correct me, Dr. Lang, if I'm wrong, I think in the Japanese experience over, like, throughout their whole data is 1.8% at most since the beginning. But I saw that there was also even something that is less or almost unheard of to have that recurrence. I did, like, from a personal experience, and I think it's related to provincial reimbursement of DOACs. We had a specific population that we did BPA on, and after you have your acute PE, you give half dose of DOAC following the 6 months. And they came in with acute on chronic, kind of like on CTEP with like fresh clot, because they were taking 2.5 of Eliquis, for example, instead of 5 milligrams. So that is a little bit different, and if people are somewhat subtherapeutic, they might have a little bit of recurrence. But in terms of like BPA data, as far as I know, it really is very, very low, if almost non-existent.
May I say one more thing? Please. I think it's a great question. Congenital pulmonary artery stenosis is a medial hypertrophy. It's almost like instant restenosis. So you dilate, it comes back, you dilate, it comes back. It's a restenotic process driven by whatever, you know, transcription factors. We all know them very well, and we code stents to prevent, which is impossible because they're too big, right? And CTBH is totally different. It's not medial hypertrophy, it's an intimal lesion that stems from organized clot. So if you, there's a figure that I drew for the PPS publications in the ERJ. Now, PPS, peripheral pulmonary stenosis, may be similar to what you are talking about. It's medial. It's not intimal nets. It's medial hypertrophy. I drew a little schematic. Please look it up. It's in an editorial in the ERJ just last month. I think it's very interesting.
Just for the sake of time, last question.
Thank you for your great talks, combining all the aspects of CTEF. Actually, my question is about after surgery, we face a few cases that still have residual pulmonary hypertension to the extent we start again medications. So my question, do we have a method that can we anticipate those kind of patients and categorize them maybe into angioplasty rather than surgery?
I think you should, my response would be, please do an angiogram after PEA surgery to nail down the surgeon 6 months after their surgery. And if you have residual lesions, please do BPA as soon as possible, because if you wait, it becomes undoable. Because of the inflammatory process that is set off with the PEA, you get very, very hard occlusions. And sometimes, you know, with the many branches, not so talented PA surgeons or not so proficient PA surgeons forget a branch. And sometimes they forget A10. And that may mean something to the patient in the long run. So I think the follow-up PAG 6 or 12 months after the surgery is extremely helpful, is a quality indicator for the surgical program, and is the starting point for BPA. I would not hesitate, you know, it's only making them better.
Okay, now we're going to conclude our session. Thank you so much for the organizing committee for their kind invitation.
You do that, right?
Thank you so much for all the speakers, an amazing session. We're going to have a 10 minutes break and then we're going to proceed with the next session. Thank you so much.
We have very beautiful feedback and updates from our partners. Dr. Abdullah Dalan will conclude SAPH, and then we have a very important satellite symposium immediately after we conclude. Please stay around. Lunch will be served immediately after the satellite symposium. Thank you and welcome everyone. Dr. Abdullah.
Thank you, Hassan. And it's about time now to start our last session. And this is not a scientific session. It's actually meant to give a chance for our partners and collaborators from different parts of the world to describe what they do for their society and their patients. And this is a year where we have actually South Korean group who are joining SAPH for the first time, and hopefully this is setting the stage for future collaboration. We have been partners with PVRI for a long time, and Karen is going to give a brief talk about that. But also this year we have the American PHA as well as the European PHA who are going also to tell us what they really do in terms of their activities. So it is my great pleasure to chair this small and short session with Professor Chang from South Korea, who came all the way from Singapore just to share the last day with us, the last day of SAPH with us, and he's going to introduce his colleague. Please.
Yeah, I'm really thanks to the Abdullah Adalahan and all organizing committee of South Arabian Pulmonary Hypertension Association. And I'm the chair of the Korean Society of Pulmonary Hypertension. The other part of Asia, we have 4 countries, China, Japan, Korea, and Taiwan has made a society, East Asian Society of Pulmonary Hypertension. We call it ESOP. I am also now the president of the ESOP. We have like these sessions in the Seoul and Tokyo and Beijing and Taiwan. So it's a great first step to cooperate with the East and West Asian societies. So yeah, we are. I'm very pleased to introduce my colleague Jae-hyung Park. Is a professor of Chungnam National University. He has a sabbatical at Cleveland Clinic and also do many articles about RV strain and also is a specialist in the cardiac imaging and pulmonary hypertension. Yeah.
Thank you, Chairman. Good afternoon, ladies and gentlemen. It's a great honor to present here my topic. Assalamu alaikum. My name is Jae-hyung Park from South Korea. It's a great pleasure to meet you here. First of all, I congratulate on this successful 17th Saudi Arabian pulmonary hypertension meeting. Korea is located about 7,500 kilometers from here. It takes 12.5 flight hours. Our capital city is Seoul, and you use the Korean and Hangul, not English. So my English is not so fluent. Our population is about 52 million. As you know, there are 5 groups of pulmonary hypertension according to underlying pathophysiology. I will focus on the group 1, pulmonary arterial hypertension now. Generally, about 1% of general population in the world have PH. So about half a million Korean may have PH. However, PAH is rare in Korea, and we think less than 6,000 PAH in Korea. I will talk about current status of PAH treatment in Korea. We want to evaluate demographic and clinical profile of PAH patient in Korea we made Korean PAH registry called COPA registry in 2008 with the collaboration of 4 scientific society, Korean Society of Cardiology, Korean Academy of Tuberculosis and Respiratory Disease, Korean College of Pneumatology, and Korean Pulmonary Hypertension Society. At that time, we were started as a study group. We enrolled a total of 625 PAH patients from 2008 to 2011 from 39 hospitals. Professor Jung published this data in 2015. Of them, 145 had IPH, and the others had APAH. Their mean age was about 48 plus minus 16-year-old. Females are predominant. And the hypertension is the most common cardiovascular comorbidity. We compared, we analyzed the PAH patient with the available right heart catheterization. Their mean pulmonary arterial pressure was 55 millimeter of mercury, and the pulmonary vascular resistance index is about 9.3 wood unit per square meter. The demographic, clinical, and hemodynamic profiles were similar that of international registry, including Libya, French, Spain, and China. In this study, CTD-associated PAH, the patient, the survivor is the worst survivor. And bosentan was the most common medication for use, and the percentage of combination was about 15%. We have 3 big data-driven studies in Korea. The first one is from used database from Korean Health Insurance Review and Assessment Service we call HIRA. And in this study included 1,307 PAH patients from 2008 to 2016. They calculated the annual incidence of PAH is about 4.8 per million per year. And their mean age was 44-year-old, and the females are predominant. In this study, 1 year and 3 year survival rate is about 85% and 54.3% respectively. At that time, the combination therapy was about 10%. And second study used the Korean National Health Insurance Service, we call NHIS database. This study included 9,000 IPH patients from 2006 to 2017. Their mean age is 62.3 years old, and the females were predominant. In this study, 1 and 5 and 10 year survival rate of IPH was 98, 89, and 72.3 and 57% respectively. Survival rate between females and males was similar, and the PAH with the advanced age was showed the poorer survivor. The latest study used the NIH data too. In this study, the prevalence and incidence of PAH increased 75 and 12-fold respectively from 2002 to 2018. And the proportion of patients on combination PAH-specific drug therapy has increased by 2.6-fold in 2018 compared to when 2007. In this data, 5-year survival rate and the median survival duration was 71 1.5% and 13 years. Currently, yearly incidence of PAH is 5.0% per year per million, and the 5-year survival of PAH is about 72%, and their median survival is about 13 years. The rate of combination therapy is on this rising up to 25%. We think our result became similar to the comparator registry in Europe. As BMPR2 mutation, we have just one study evaluating the percent of BMPR2 mutation. BMPR2 mutation was found in 22% of Korean IPH patients in Pilgrim registry. The Pilgrim registry is a prospective, investigator-initiated, multi-institutional study to evaluate the hemodynamic profile of inhaled iloprost. Compared with the non-carrier, BMPR2 carrier showed earlier symptom onset and more severe hemodynamic profile in this study. Actually, we made a Korean guideline for PAH in 2020 based on 2015 ESC guideline. In this guideline, we included the Korean data and the recent studies of PAH. We have several problems in the treatment of PAH. This is the proposed treatment guideline. Recent ESC guideline recommended the initial combination therapy even in PAH patients with low or intermediate risk. However, Korean government did not permit initial oral combination therapy in PAH patients with low or intermediate risk. And this table listed several PAH treatment drugs. Unfortunately, there is several drugs are not available in Korea, including tadalafil and the IV ibuprostenol. So we insisted to the introduction of these drugs to Korean government. I will talk about the Korean Pulmonary Hypertension Society briefly. This is the webpage of our society. And the main is the history of KPAH. We started as a working group for COPA registry since October 2007. We made the officially established workshop group on the Korean Society of Hypertension in January 2017. The first KPAH workshop was held on March 4th, 2017. After that, we held additional 5 scientific symposia until 2021. And we started as an isolated scientific society since July 26th and 2022. And after that, we held 2 scientific symposia until now. And last year, we made a textbook for PAH. And this textbook have A to G about PAH for beginners, not like you, expert. And currently, the Professor Jung is our president, and I'm the Secretary General. We have 34 directors and 200 official members. They are mainly mainly cardiologists. And we have several projects. The first one is the Phoenix platform. We want to make a nationwide multi-center registry and biobank program for deep phenotyping for pulmonary hypertension in Korea. Phoenix means PH platform for deep phenotyping in Korean subject. And we included the nationwide 25 key hospitals in Korea. And we made a national registry for enrollment, follow-up, and check long-term clinical outcome. And the clinical data were stored. I create this is the national data warehouse, and the biospecimen was stored to the biobank to further analysis of genomics, transcriptomics, metabolomics, and proteomics. This is the way of sample storing. Initially, we started to make a registry for IPH and HPH first. In the future, we extended the old group. And we made an infographic for PH screening program, PE-MIRI campaign. PE means long, and MIRI means early. PE-MIRI is a homophone of family. So in this infographics, it gives the patient many information. And we performed a parliamentary debate on PH in the National Assembly in Korea 2019. We also continue to push the Congress and the government to do better treatment for pulmonary arterial hypertension. And I will introduce ESOP briefly. Because the population of East Asian region is about 22% of the world, the PH experts from South Korea, Japan, China, and Taiwan came together to create a conference to promote PH treatment in this region. And the first ESOP symposium was held in 2019 in Taiwan. And the second ESOP meeting was held online 2021 because of COVID-19. Last year, we held the third ESOP symposium with PH Korea in Incheon. And the fourth ESOP symposium with PH Korea 2024 will be held in this July in Seoul. Please join us and to share your knowledge and the insight at the meeting. I think the collaboration is necessary for better PH treatment. So collaborate with us. Thank you.
Thank you so much. I think we should have West Asia joining East Asia now for the collaboration. Thank you so much for coming. So it's my pleasure now to introduce Karen Osborne, who is going to do 10 minutes presentation about the activities of PVRI. Thank you, Karen, for coming.
Can you hear me? Great, thank you. Once more, thank you so much for the invitation to speak. It's lovely to be here, and congratulations on such a wonderful meeting. The Pulmonary Vascular Research Institute has the aim of reducing the global burden of pulmonary vascular disease. And we do that by advocating, collaborating, and educating. And with perfect timing, given the previous speaker, I want to talk about collaboration today. And particularly, I come here to ask you two things. I need your help. PVRI needs to collaborate with everybody in this room about two projects that we're working on at the moment. So the first one, you can see on this diagram here. These are some of our global work streams. These are multidisciplinary work groups, each of which focus on a particular challenge in the field of PVD. And the one that I'm going to talk about today is patient engagement and empowerment, the one at the bottom there. So, about 2 years ago, our patient empowerment group started a piece of work to develop a global patient survey. And the aim was to understand the impacts of pulmonary hypertension on adults, on the pediatric population, health-related quality of life, and to really dig deep into patients' experiences of healthcare, of research, and of self-management. And it was the first global survey of its kind. So it took a long time to pull together, and here is a list of just some of the people who've been instrumental in the group and the survey. It's co-chaired by Joanna Pepka-Zalba, in Cambridge, and Matt Granato, who's going to speak in a moment, who's the chair of PHAUS. And I'd also like to particularly mention Hull, who is with PHA Europe, who's also here today, who's going to talk, and Joe Newman, who is a researcher at Cambridge, and he's doing the first kind of cut of the data, the first analysis. Okay. This is one of Joe's slides, and I seem to have done something rather peculiar to it. There we go. Okay, this is a kind of a snapshot of the survey. There are 300 questions in the survey, but the survey has 3 arms. So you go down a different route depending on who you are. So if you're a patient, you go down one arm. If you're a carer for a patient, an adult patient, you go down another arm. And if you're a parent or carer of a pediatric patient, you will go down another route. And so usually, depending on the route you go down, the survey will take about 20 to 30 minutes to answer, and each response will generate about 100 data points. So we launched the survey last autumn, sort of October, November time, and we launched it in 17 different languages. We added another 6 about 2 weeks ago in February, and actually we have 89 countries represented now. I checked this morning and we're approaching 4,000 responses, but we have some gaps. This is just to illustrate, with Joe Newman, who I mentioned earlier, he's doing the first cut of the data, the first analysis, very, very early days yet, because the survey is still live. It's going to run through till summer this year, so we've only just started to look at the data, but there are some bits and pieces here that I thought might be of vague interest to you. I'm going to whiz through them. And just to touch again on what we're going to do with the results of the survey. If the survey works, PVRI is committed to rerunning this every perhaps 3 or 4 years to make this a kind of a permanent source of data, of information to all of us. This is going to be widely available data. We're going to share it with the patient organizations who've helped us, and we're going to share it with all our collaborators. So this is slightly out of date. It's a little aged, but you'll see we have relatively few responses from Asia, and particularly from this region. When I last checked, we had 1 patient from Saudi Arabia who had responded, 1 from the United Arab Emirates, 3 from Iran, but none from Jordan, Oman, Qatar. So we really, really want to engage, and this is our fault. PVRI has not yet been able to translate this survey into Arabic, and that is one of the first requests that I have for you. As I said, we have 23 languages at the moment. All of those translations have been done on a voluntary basis by people like you, by fellows, by patient organizations, by patients themselves, by senior clinicians in some cases. And we are incredibly grateful for that, because it's quite a big piece of work. There are 300 questions. It has to be done really, really carefully, obviously, because we're pulling the data in an automated way, and it has to be checked. So once the translation is done, we have, there's a beta testing process where we check it out on 2 or 3 patients in that language, make sure it works. So this is the first thing that we need help with, and I'm really, really hoping that there is 1 person or 2 people in this room who might be able to help us with the translation. The second thing, we do have it available in many languages at the moment. It's in English, it's in French, Spanish, many others. If you have patients who speak those languages and who you think might be willing to participate and do the survey for us, please share the survey with them. The QR code will take you to PVRI resources, which are aimed at patients. They've been developed for clinicians to share with patients. There are some videos in different languages of patients saying that they've done the survey, why they've done it, why they're engaged, why they want to take part. And there are lots of sort of printed materials, posters you can put in your clinics, and QR codes and information that you can give to your patients. And the third favor, if anybody is interested, we do have, the work stream is participative. The strength of all our work streams come from the collaboration of all the members. So if we have any PVRI members here who would like to get involved in this work stream or in any of them, please let me know, because we would be delighted to have you on board. Okay, this is the second favor. This is a global pH meta-registry. Called Go Deep. It was started about 4 or 5 years ago. It's led by a team of researchers at Gießen in Germany. And it aims to expand our knowledge about pH, to use information about epidemiological differences to gain a better understanding of pathogenesis and foster better treatment, ultimately. So if a centre joins up to participate, they will send their anonymised patient data from many centres around the world into Gießen. The data set consists of about 350 parameters, typical things that you'll all be using in clinic every day. So any centre that has an existing database of over 100 PH patients diagnosed by right heart cath can join Go Deep and join the consortium free of charge. There are benefits of being involved. One of the benefits is access to data. There are two levels of access to the data. First level is exploration and feasibility analysis, and second level is unrestricted access to answer specific scientific research questions. And all consortium members can access both of those levels free of charge. So this is another map, and it shows a kind of bald patch, really, where we are now. We don't have very many collaborating centres at the moment, and so I'm here to try and fly the flag and engage you all in that. Some of these figures here, actually, we've increased that now. There are more than 30,000 patients involved, more than 7 million data points, and the richness of the data, it's just starting to get interesting. These are the members who've been involved for some time. We have, where are we? UAE, yes, we have the Cleveland Clinic in Abu Dhabi, which is great. So they've been on board for a while. These are members who are, they're engaged, they've signed up, and they're in the process of transferring the first sort of tranche of data. And these centers are in discussion with Go Deep. So South Korea, good to see, and the Aswan Heart Center in Egypt as well. But we would love more involvement. We really, really would. And it obviously resonates with people. There's a number of people who've spoken about registries today and about the use of data and about collaborating and sharing data. This truly is a collaborative project. We would love to have you involved. These are just one or two of the papers that are either in preparation or in submission. Again, it's quite early days. They waited quite a while to get the data to make sure all the systems were working first, but it is starting to produce some quite interesting information. And any of you who are interested in international collaboration, it is a truly global collaboration. There will be people involved in these other centers who will have the same interests, the same research needs as you, and who would be wanting to collaborate. So I really hope that there are benefits to members as well. Beyond just sharing your data, you will get something back from this. So these are our contact details. That's my email address. You can also contact us via our website. If you're able to help with any of these things, I would love to hear from you. Collaboration is absolutely central to our effectiveness and to our ethos and our values. So yeah, we'd love to work with you. Please come and talk to me afterwards. I'd love to talk to you. Thank you very much.
Thank you so much, Karen. So it's now PHA presentation by Matthew Granato. So please, Matthew, the podium is yours.
Thank you again for inviting me, and as co-chair of the group that Karen was mentioning earlier, I'd like to also urge you to join the PHGPS. So last time I was here on day one, I talked to you about how PHA started. Today I want to talk to you about the actual programs that we implement to fulfill our mission, which is to help improve and extend the lives of patients with PH. So one of the first things that we do, or that we focus our time and effort on, is advocacy. So what is advocacy? Something very common in the United States. So what we really do is we try to influence legislation and judicial response. So this is also known as lobbying, probably, more commonly known as lobbying. And what we try to do is to work with policymakers, regulators, legislators, so that the laws of our country really reflect the needs of the PH patients, and also the providers like you who need to work with PH patients. So this is actually a picture of us on Lobby Day, where we all go to Congress and we talk to different legislators about the needs of our patients and the problems that providers have in serving our patients. Another part of advocacy is awareness. is ensuring that both the public and those who are at risk of developing PH know about PH and they can act quickly. We all know that this is a disease that's a race against time. So the earlier the diagnosis, the better they can do. So we disseminate a lot of information to educate the public and patients that are at risk of developing PH about the condition. We have a guide called Navigating PH, which anyone can order on our website, that it really is for newly diagnosed patients, that it walks them through their disease and what they can expect during treatment. We also launched the guide in Spanish. And we have several brochures that explain the relationship between PH and the different conditions that can lead to PH. Another important part of awareness is our website and ensuring that our patients and providers can find all of those resources in one hub. So we recently launched the PHA Connects Hub, which is one-stop shop for all information about PH. With that QR code, you can get to that microsite that we've developed to download all sorts of materials, education materials, and to participate in different webinars so that patients can get information about how to manage their disease. I mentioned when I was here on Friday that the 4 women that sat around the kitchen table talked about support, psychological, mental health support when they're diagnosed with this very little known disease. So one of the things that we did early on, and it has developed into a very large network, are support groups. These support groups are led by volunteers, most of them patients themselves, some of them caregivers, and also healthcare professionals. They meet often. During the pandemic, they had to meet virtually, but now they meet often in person, sometimes at a hospital that lends them a conference room or at a restaurant or someone's backyard, and they talk about the challenges of living with PH. We support that financially and through resources at PHA. There's over 200 support groups with over 260 volunteer leaders that lead them. We also have a peer mentor program that allows those recently diagnosed patients to be paired with a patient who's been living with the disease for a long time, and they can walk them personally through the challenges, the first shock of being diagnosed with this disease. And finally, we have a support line that patients can call and ask questions and be informed or educated about what's next when they are diagnosed with this disease. And finally, we talk a lot about education, educating patients, educating family members, educating parents of patients. So we have different avenues by which we do that. One of our programs, it's called PHA Classroom, which is basically a compendium of recorded webinars that patients can access anytime, anything from side effects of the medications that they may be taking, or exercise, or diet, or intimacy, things like that. We also have a bi-weekly newsletter, PHA Connects, that has information, and we have live webinars, so providers like you would be talking to patients live about different topics, and patients have the opportunity to ask questions. Education is not just for the patients. I mentioned when I was here that we are a hybrid organization, a mix between a patient advocacy organization and a medical society. So a lot of the education that we do is also for providers like you. Currently, we have over 35 credits of CME in 42 online courses that providers can access through our website. We also do a symposium every other year, mostly targeting nurses, allied health professionals who are critical in caring for patients. And we also have this program called PHA On Demand, which is basically ground rounds. We send experts to the different clinics around the country to give ground rounds, and those members can request those experts to come to their clinics. And finally, we have the scientific sessions of the PHA conference. Some of you may be familiar, may have attended. So I wanted you to be aware that the scientific conference, scientific sessions are happening mid-August in Indianapolis. This is sort of the agenda for the scientific conference. One of the things that we're really going to talk about is the World Symposium that is going to happen in Barcelona 6 weeks earlier. So again, if you can't make it to Barcelona, I hear Indianapolis is a good second. And we also have a partnership with PVRI, where we have joint sessions at their Congress and our Congress. So I invite you to check out the meeting in Indianapolis mid-August. Another really important aspect of our mission is to ensure that standards in PH are followed and applied. And 10 years ago, we launched an accreditation program, the PHCC. This program was based on guidelines and standards that were developed by a committee of scientists and basically centers around the country. And now this is open internationally, so any center anywhere in the world can apply to be accredited. And so a group of reviewers comes to the centers, reviews the centers based on a checklist and certain criteria, and accredits that center for 3 years. And every 3 years, there's a renewal of the accreditation. Currently, we have over 87 centers accredited in the United States. Some of them are pediatric centers. And we have a really long wait list. There's a very popular program among centers in the United States. They all want to show the flame that they are being accredited, and patients feel comfortable being treated at a center that's been accredited by the PHCC program. Those centers, those 87 centers, also maintain a registry. We have the Pulmonary Hypertension Association registry. It is a registry among 71 of those 87 centers. It currently has over 2,700 patients. It's PAH and CTEPH patients and pediatric patients as well. It is a prospective longitudinal observational patient registry, and would love to join Go Deep as well. And what we do is we collect patient data when they're first seen at the center, and then every time they go for treatment, their data is updated. Any scientist or any clinician, any investigator at any of the 171 centers that are participating have access to the data. They can conduct research out of the registry, and they can request particular research questions to be added to the registry, to be asked of all the patients that are participating in the registry. I wanted to give you an idea of the success of the accreditation program and some of the data that we can pull from the registry. Do not pay attention to 2016. That's data with very little data points. So just look at 2017 through 2022, just to give you an idea, again, of how the ability of the centers to compare against each other and to follow certain standards has actually had an impact on hospitalizations, death, and functional class at enrollment. So we really consider this program a success. We're on the 10th year of the program, and now, like I said, it's open internationally, so it's not just US centers across the world that are interested in joining the accreditation program, and the registry are able to do so. So that's my presentation, and if you have any questions, here's my contact information. Thank you so much for listening.
Thank you, Matt. Thank you so much. Now it's PHA Europe. Hall Sakara will be presenting his activities. Thank you, Hall, for being here.
Hello. Thank you so much again for inviting me and inviting PHA Europe. So my name is Hall Sakara, and I work for the European Association. And I might actually be the only patient in this room. You talk a lot about patients, and I'm one of them. So this is me. I was diagnosed back in 2005, so 19 years ago. And I had quite severe PH, but I'm still doing okay 19 years later on monotherapy. So PHA Europe is an umbrella association. So the members are national associations. So we don't have any patients as members of PHA Europe. So we have 37 national associations that are members, and we represent about 15,000 PH patients. Most of these associations come from Europe, but we also have members outside Europe. As you can see, China, Japan, Argentina, and we also have a great collaboration with Matt and the American Association. So we do a lot of activities similar to the American Association. We have 4 pillars, main pillars. We work with awareness, capacity building, advocacy, and information. When it comes to information, we have two journals a year, Mariposa journals. If you go to our website, you can read these, and these will show you the activities of the different associations. Also, in 2012, the Spanish Association started a World PH Day event on May 5th. So this was unfortunately a small boy that died on May 5th. So in honor of him, we made the World PH Day event. So this is an event now that has become a global event that we have a lead on. And we develop different graphics that can be used by all associations around the world to be posted on social media and so on. So this is going to be the next graphic we're going to have for upcoming event. And here you can put your logo of your association. So during this day, the different associations perform a lot of activities. They color buildings blue. They have a lot of other activities using the templates that we provide them, like the T-shirts and so on. When it comes to capacity building, we have helped start many associations in Europe, about 20 associations. So this is a photo from 2012 where you can see the countries that did not have an association or that were not member of PHA Europe, and we helped them to start associations. So now there is almost no white spots left in Europe. Also, we help to empower the patients by running webinars. This is one of the most popular webinars we had by Professor John Gain, who spoke to us on the last World PH Day. We meet once a year in Barcelona, and we pay for 2 participants from each of our associations, and it's almost like a family gathering in November in Barcelona at the annual PH European Conference. And last year, we were very lucky to have a speaker from Saudi Arabia, Dr. Krimli, together with other honorary speakers as well. When it comes to advocacy, we work on a national level. If there is an association country that has problems with access to medication, we assist them. And also we work on an EU level. So this is from the EU Parliament, where we had a call to action. And you can read more about this on our website and read the entire call to action document. Now I would like to talk to you about something that we call the Bel Air Center. And we just opened it prior to this conference. And we're going to have a grand opening on the 29th of February, which is the rare day. So this is like a virtual conference center hotel. And the reason we call it Bel Air Center is because the hotel we usually met at in Barcelona is called Bel Air Hotel. And this is a copy of Bel Air Hotel. So here you can meet the different associations, you can see presentations, you can socialize, etc. So once you enter the center, you get into the reception area, and I'm the receptionist, and I greet you. You can ask me any questions or leave a comment. Our President, Eva, has a video message, and you can move around there on the left side to the different areas of the center. So, for instance, we have a podcast area. We have almost 500 podcasts by doctors and patients. We collaborate with PH Aware about this one. We have an art gallery where patients who made art contributed. And also we have some PhD doctor that contribute with artwork. And also we have videos, like for instance, Professor Adam Tybicki from Poland. He is playing piano and has a video in there. We have a social area, so everyone that's logged on in the platform, you can chat with them and do video conferencing, almost like a Zoom conference. And if you dive into the presentation room, you will find all the presentations with a search feature up there. There's been a lot of talk about AI within medication, but we also utilize AI to dub these presentations. So for instance, Professor Gain, he's speaking English, but we use a tool to make him speak German, Chinese, etc. perfectly. And the tool even takes his voice, so it sounds like it's him speaking in perfect German or Arabic, for instance. So if your patients are logged on to this, please let us know if you have any preference for any of these presentations that you would like to have dubbed in, for instance, Arabic. So we also have live presentations, and we will have the first live presentation on February 29th, as I mentioned. Professor Malcolm Bell will speak to us. And once this presentation is over, we will move it into the recorded presentations. Then we have booth areas, like the booth next to here, where the pharmacy companies present their products and so on. And we have an area for all the PH associations. So here are the associations again. And if you, for instance, click on the Austrian Association, then you get up information about them, documents, videos, and so on that they have uploaded. And you can translate everything into your local language. So we support almost all the languages of the world. So this is something I would encourage you to talk to your patients about. Let them become member of this club. It's free of charge, of course. And then they can log on and they can translate everything into their native language. And the same also with these documents that this association has uploaded. So for instance, the World PH Day event in 2023 can be translated into local language. Here is a brochure about this, and you can use the QR code in the back to get to the landing page where you can register. So I would encourage doctors and patients, carers, etc., to go in and register and become member of this club, free of charge. And you can get access to all these things that I mentioned. So Eurordis is awarded us in 2018 as the best umbrella association in Europe. And this lady here in the middle is one of the patients. She is the leader of the Ukrainian association. And she's actually my wife. So we are a very rare couple with both husband and wife being patients. So thank you very much.
Thank you for the nice presentations. I believe to overcome pulmonary hypertension, we need more collaboration and cooperation among patient, doctors, and PVRI, European PHA, and the PHA. And also, I'm the president of East Asian Society of Pulmonary Hypertension and Korean Pulmonary Hypertension Society. All people's collaboration is needed to overcome PH. And I found the 17th anniversary annual conference of this Saudi Arabian Pulmonary Hypertension Society. Also, my society starts from 16 years ago, first registry programs. So yeah, we met today first, and we also invite you to the Pulmonary Hypertension Korea with East Asian Society ESO meetings in July 19 to 20 in Seoul. So we make joint sessions with this South Arabian Pulmonary Hypertension Society. So it's a first step to cooperate to East and West Asia. It's a great meaningful moment. So, and thank you for all speakers from the PVRI, PHA, European PHA, and also Korean Pulmonary Hypertension Society. Thank you for all. I close this session, and the closing remark by Abdullah. Okay. Thank you.
Well, I think we're coming to the end of this beautiful journey. We had a great 3 days, great in all aspects, in science and having networking with the colleagues from everywhere in the world. Great of having new collaborators from South Korea, and also having new speakers from United States. This year we increased the number of United States participants. I think also we got the privilege of having some new data mentioned only at SAPH this time, and this is also great news. It really gives me a great pleasure to thank all of you for sticking to the last minute, and people are actually standing, having no seats, although there are some seats in front here. But thank you so much for sticking to the last minute for such a great meeting, and meeting all these great speakers from everywhere in the world. This event would not have happened with the help of our partners from pharmaceuticals. So again, I'm thanking you, and we hope to continue this partnership for years to come. It's also my great pleasure always to thank the man behind all such great organization, who is paying details to the smallest paying attention to the smallest details ever, and who is sometimes pain in the neck, because, yeah. So please thank Mr. Hassan Al-Oraini for such a great job. Thank you, Hassan, always. Let me also thank our audiovisual colleagues. Thank you so much for such a great work. Thank you. All those magnificent lectures by magnificent speakers are actually recorded in many platforms. So you can actually access them in YouTube anytime you want from here to a few years to come. This is also have been a great effort by Hassan, who pushed hard to have it live streamed using different platforms. I can tell you also the number of attendees physically has been the highest in many years, but also people who actually attended the talks on different platforms were actually in hundreds, maybe thousands as well. So this is great, and I think the message and the awareness and the knowledge of pulmonary hypertension has been spread widely this time using technology. I was told that there will be a short, only 15 to 20 minutes symposium after officially concluding SAPH. But also, please, it is our custom to have a photo of all the speakers, chairs, collaborators, and SAPH members, as well as the audience. And my request is please stick to the last minute. So after the conclusion of this symposium, we will have a group photo. So thank you again, and we'll see you. We haven't decided when to hold the next SAPH, but it is going to be in the same date, February 13th to 15th. The decision will be made after SAPH board members in the coming few months, and this will be announced. Thank you so much. See you next year. The satellite symposium is actually titled Raya and it's the light at the end of the tunnel. So probably tackling patients in the low intermediate risk stratification area, and it's going to be presented by Dr. Majdi Idris.
Okay, assalamu alaikum again. Thank you, Abdullah. So I always feel bad when I feel that I'm the person who not allowing you to go to lunch, but hopefully this wouldn't take a long time. So as you know that this lecture is sponsored by Bayer, and we're going to talk about mainly the impact of riociguat on the right ventricular function. So as we know that the never-ended philosophical debate about is it like the right ventricle or it is the pulmonary vascular resistance that's actually causing the trouble in patients with pulmonary hypertension. Having said that, we know that what really matters at the end, that we deal with both, that we kind of improve the right ventricular function by decreasing the pulmonary vascular resistance. And it's kind of that of understanding of what we call the basically RV-PA coupling, which means that as long as the right ventricle is able to generate a cardiac output against the high afterload that is usually formed by the basically increasing PVR, then the patient is doing okay. As long as this really RV-PA uncoupling happen, then the patient is in trouble. And we know that in general, the right ventricular basically pushing forward the blood to great extent depends on the contractility, which depends again on the really inotropic effect and on the myocardial hypercontractility and hypertrophy, while the PVR from the other side depends on the vascular resistance and the pulsatile load. So we have this basically ratio between really end asystolic elastance that really basically form the right ventricular afterload generation basically force, and the arterial elastance that reflect basically the afterload. As long as this is more than one, the RV is okay and can generate adequate cardiac output. But we know that from many, many studies that it's not enough to decrease PVR by itself. We need to decrease PVR significantly in order to this to be coupled by improving in the right ventricular ejection fraction. And we know that at least you need to drop the PVR by 50%, at least 50%, before you can get kind of a meaningful improvement in the right ventricular ejection fraction. And as a matter of fact, when you look at what we now consider as the goal of therapy, it's all about the right ventricle. The symptomatology, the exercise, basically performance, and the RV function that we are measuring directly or indirectly by biomarkers, imaging, or hemodynamics. It's all kind of an assessment of how much this RV-PA coupled, that the RV is able to generate cardiac output against the high, basically, afterload. And so far, we were using three main treatment, basically, pathway. Now we have basically more than that, as we heard earlier in this meeting. But when you look at the nitric oxide pathway, it is a unique pathway because now we have two different medications from two different classes that work on that pathway. So we have the phosphodiesterase 5 really inhibitors, and we have the riociguat, which is directly stimulating the soluble guanylate cyclase enzyme that is important in the conversion to active cyclic GMP, and then inducing all the good effect from antifibrosis, vasodilatation, and anti-proliferation. If you look at the animal data, looking at the effect of riociguat on those animals who were having, these were mice that they were treated by the pulmonary artery basically banding, and then they were treated by either sildenafil or riociguat for 14 days. And what they found that if you look at those patients after the treatment with riociguat or sildenafil, there was a significant improvement in the right ventricular systolic and diastolic pressure, indicating that these molecules basically improve the remodeling process of the right ventricle. And the right ventricular ejection fraction kind of improved once riociguat and sildenafil were introduced. But more importantly, I think they look at the effect on the fibroblast and on the really fibrosis in the right ventricle. So this is not something that we think about when we talk about vasodilator therapy, that these drugs, they are simply vasodilator. Probably there is something beyond that, and that the effect on the fibrotic scarring and on the fibroblast function in the ventricle. And we know that in this kind of nice paper, that what they did, they take basically the cardiac fibroblast and they subjected it to transforming a growth factor beta. And they look at what's going to happen in the response. And you can see that both sildenafil and riociguat blunted that effect. But it was only riociguat, not sildenafil, that reduced the total RV fibrosis scoring. So again, looks like that basically riociguat has a direct anti-remodeling effect. And looking on the drug effect, again on the animal data, on the muscularized vessels that are formed in usual pulmonary hypertension, this was experimental animal data, riociguat was significantly able to blunt that effect, again, improving that what we call is the remodeling process. The final animal study, this was an interesting study because now they look at what happened. This was, although on the left ventricle, but it again proved the concept. They ligated the pulmonary, they ligated the coronary arteries in rats, and they basically induced ischemia and infarction. And then they used riociguat 5 minutes and 1 hour after the ligation. And they looked at two things. They looked at the infarction size, and you can see that riociguat blunted that or significantly attenuated the extent of really scarring and the infarction that happened with this ischemic insult. And that was not affected by using nitric oxide synthetase, basically inhibitors, again indicating that the dual mechanism of action of riociguat, troponin, and riociguat treated group were actually better. And looking at the cardiac MRI and really basic dynamics, and find that the ejection fraction, again, was better in those patients who were treated with riociguat. The message was repeated that those patients getting some protection at the cellular level by using riociguat. So what about the human data? And we had this RIVER study, a nice study. They looked at the patients who were recruited from basically other clinical trials, the PATENT Plus, EAS, and the CHEST. And they followed about 40 patients for really 1 full year. 27 patients completed the full year. And they look at what happened after they were treated with riociguat compared to those who did not complete on riociguat. And they looked at different endpoints reflecting, again, the right ventricular function. So they look at the RV service area and the right A service area, and you can see clearly that riociguat helped in reducing both that. So basically, the RV dilatation, that is usually the sign of really uncoupled, basically RV, significantly improved with riociguat, and the TAPSE scoring, that's in a way reflecting the contractility of the right ventricle, improved as well. So giving, again, an image that we are not working only on really very distal PVR as a vasodilator therapy, but we are working more centrally, really on the right ventricle. Many other studies showing that the cardiac dilatation improved with continuous riociguat treatment. Another study looked at, again, the patient who recruited from the PATENT and the CHEST. I'm showing you here basically only the PATENT study, who were treated with riociguat, and look at other endpoints reflecting RV function. Not only, again, we're not talking here about the clinical endpoint, but really looking at RV function, so looking at basically stroke volume index. They look at the cardiac efficiency, they look at the RV work. All of those reflecting RV function showed very, very significant improvement in these different endpoints, reflecting better improvement and recovery of the RV function with riociguat treatment. and using a ratio between the stroke volume index and the right atrial pressure to assess the efficacy of the drug in order to improve survival. We know that, for example, stroke volume index more than 31 is really associated with a negative correlation with REVEAL risk scoring. So basically, and this is why it's now used at the intermediate risk, that you would like to get stroke volume more than 31. We know that RA pressure increase more than 10 or more than 8 is associated with really worse outcomes. So it's kind of this ratio between stroke volume index more than 31, RA less than 10, indicating better outcome. And that's been shown that those patients who really satisfy this basically ratio had improved mortality. And when you look at what happened when those patients were treated with riociguat, so basically the green zone are those people who, as a matter of fact, basically fulfilled this ratio, so improved their stroke volume to more than 31, dropped their right atrial pressure less than 10. Those were improved with riociguat treatment from 51% to 65%. And those who were on the red zone, so those who did not get both low stroke, basically high stroke volume and low basically RA pressure, dropped from 18% to 7%. Of course, those who were not treated by riociguat get the opposite direction, again indicating improvement in the RV function. We know that when you look at the post-hoc analysis from the RESPIRE trial in those patients who were shifted from sildenafil to riociguat, again trying to look at basically stroke volume index, and cardiac efficiency, which is usually stroke volume index over mean pulmonary artery pressure. Cardiac efficiency was better in those patients who were shifted from phosphodiesterase 5 inhibitors to riociguat treatment. And finally, looking at basically the clinical endpoints from the clinical trials, we know that in phase 2 trial, riociguat really improved hemodynamics and improved the 6-minute walk distance. But in the two major phase 3 trial, the CHEST trial, basically addressing CTEPH patient, riociguat improved the primary endpoint. It was the first drug to do that in the CTEPH patient and the primary endpoint. And very similarly in the pattern study in the PAH patient, where riociguat did as well the clinical endpoint by improving 6-minute walk distance in treatment naive and those who were on background therapy, and improve as well the secondary endpoint. So, and this is why, based on many data, including the RESPIRE data, the CHEST and the pattern study, now the guidelines has adopted this strategy that riociguat now is being used as a tool to improve the outcome in those patients who fail to reach the green zone after the initial basically combination treatment. And now we have an option of not to add therapy, but to switch from basically phosphodiesterase 5 inhibitor to riociguat in order to improve the outcome of those patients. So take-home message to you, ladies and gentlemen, I think data is convincing that riociguat work beyond the simple vasodilator basically function that is very important in the pulmonary arterial hypertension to decrease the basically afterload, but it goes beyond that to work on the RV function basically itself. It improved the basically efficiency, it improved the basically less fibrosis, improved the remodeling in those patients, and it showed from many, many studies that it improved the endpoint, including the stroke volume index over the right atrial pressure. And I think data is showing that really once we really optimize the care, including optimizing basically this treatment within the nitric oxide pathway, the patient's outcome both in the pulmonary arterial hypertension and in the CTEPH patient improve to a significant level. And with that, I would like to thank you very much for your attention.
Thank you so much. Thank you so much, Majdi. I think we are done now, and it's time now for the photo, group photo. So please, all the speakers, chairs, partners, guests, come over here. And of course, staff members.
The rain is falling, falling. The rain is falling, falling. The rain is falling, falling.